Good morning, everyone. Let me start the inaugural academic activity of SIMCON 2020 in this pleasant morning in the city of Kandy. We physicians always encourage research among our membership in view of advancement of medicine. Before starting, let me brief the time allocation and instruction for the presenters. So the allocated time for the presentation is 8 minutes, followed by 2-minute discussion. So you are kindly requested to stick to the time. There will be, after 8 minutes, screen will be blanked. Then after 2 minutes, again it will be blanked. So an award is given for the best paper with higher scores. The final mark of the paper will be the average marks given by the assessors. So to start with the first paper. First paper is Place of Ischemia, Modified Albumin and Protein Thiols in Early Detection of Acute Coronary Syndrome. Karunaratna NDD, Yatavara MD MLDK, Sivakanesan R, Thalapanava DMPUK. Presenter, Karunaratna NDD.
Good morning, all of you. I am NDD Karunaratna. I did my undergraduate research on place of ischemia, modified albumin and protein thiols in early detection of acute coronary syndrome. This study was conducted under supervision of Professor Udaya Ralapanava, Professor Sivaganeshan and Professor Lalini Atavara. ACS is presented due to alteration of myocardial blood supply and oxygen demand. The reduction of blood flow will lead to myocardial necrosis and acute coronary syndrome. These are the risk factors for acute coronary syndrome. ACS can be identified as major non-communicable disease in Sri Lankan population. Elderly people can be identified as major risk group for this condition. There are 3 types of acute coronary syndrome: ST elevation myocardial infarction and non-ST elevation myocardial infarction and unstable angina. When we diagnose these 3 types, there are some properties. ST elevation myocardial infarction can be diagnosed using ECG and positive troponins. In non-ST elevation myocardial infarction, there is a non-ST segment elevation or ST depression in ECG and positive for troponins. In unstable angina, there is a non-ST segment elevation in ECG and negative for troponins. According to that, there are some difficulties in diagnosis. Non-ST elevation myocardial infarction cannot be diagnosed using only ECG. Cardiac troponin is essential. Unstable angina cannot be diagnosed using troponins because negative value for troponins. Also, cardiac troponins take 4 to 6 hours to rise after myocardial injury and not significantly rise in reversible ischemic condition. Because of that, the novel biomarkers are needed. Ischemia modified albumin is a type of albumin which modified due to ischemic condition. It is increased within 6 to 10 minutes after ischemia. And oxidative stress can be used as a diagnostic parameter for ACS. The most important antioxidant barrier is protein thiols in humans. The reducing thiol levels is contributed to the severity of acute coronary syndrome. These are the objectives of my study. General objective is to identify the usefulness of IMA and protein thiols in early detection of acute coronary syndrome, and 3 specific objectives: to differentiate the type of ACS, exclude the non-ACS persons, and to confirm unstable angina. This is an analytical cross-sectional study performed in Faculty of Medicine, University of Peradeniya, and 51 confirmed ACS patients were included in the study group and 30 healthy individuals were included in control group. Ethical approval was obtained from Ethics Review Committee, Faculty of Allied Health Sciences, University of Peradeniya. Demographic data, clinical history and blood sample of the persons were collected with their consent. Question method is used to measure the protein thiols in the serum. Flowchart will show the process of protein thiols assay and as well as schema modified albumin assay. Statistical analysis is performed by SPSS. Let's move to the result of this study. There is a not similar distribution of male and female in the case group and control group. Because of that, control group was divided into male and female and calculate the mean IMA and protein thiols. Then analyze for significant difference. There was no significant difference between male and female for IMA and protein thiols. Also, the mean age of control group and case group not similar. Because of that, the control group divided into two age group and calculate the mean IMA and protein thiols. Then statistically analyze, it show the not significant difference of IMA and protein thiols between these two age groups. Then mean IMA and protein thiols were calculated between control group and ACS patient. It shows a significant difference between control group and ACS patients. Then IMA mean and protein thiols means were calculated for each type of ACS and statistically analyzed. It shows there is a not significant difference among these three types for IMA as well as protein thiols. Especially unstable angina group and control group was compared to IMA and protein thiols. It saw significant difference between these two groups, IMA and protein thiols. This both assays is high sensitivity and around 65% specific. According to the result of the study, protein thiols and ischemia modified albumin were not significantly different with age and gender, as well as not significant difference among type of ACS. But there was a significant difference between control group and ACS patients. And it can be used to identify unstable angina patients from non-ACS patients. IMA and protein thiols are independent from age and gender of the person. Because of that, the demographic data of the case and control group will not affect the outcome of this study. So, IMA and protein thiols can be used as an early biomarker for diagnose ACS as well as confirm the unstable angina patients from non-ACS persons. But there was a poor differentiation ability to identify the correct type of ACS. The general objective of the research was achieved, but specific objectives were partially achieved. For that, further studies with large sample size can be suggested to include these two assays to screening or confirmation test panel of ACS. The conclusion of the study, IMA and protein thiols can be used as an early diagnosis for ACS patient and also to confirm the unstable angina patient from non-ACS persons. But there was a poor differentiation ability to identify each type of ACS. These are the references for this study. And I like to thank my chief supervisor, Professor Udayarala Panava, and my co-supervisors, Professor Lalini Yatavara and Professor Sivaganeshan, Dr. Malka Mudalige, Head of the Department of Faculty of Allied Health Sciences,
Okay.
University of Peradeniya.
Let me wind off, and paper is open for discussion.
per one sample analysis, there was around 200 rupees for reagent. In Sri Lankan population, there was a scarcity of studies about ACS, but in international studies, there was some studies about IMA, but there was a few studies about protein thiols.
Can I ask a question? You told that there's no difference in gender and age with this. So why did you told that the age control groups and other group is different and there is a problem with that?
The mean age of control group and case group was difference.
So if there's no difference in the gender and age,
yes.
So are there any as a reason for separate that particular group?
Yes, there I introduced risk factors for ACS. When we selecting control persons, we exclude the persons with non-communicable disease like diabetes.
Okay, thank you,
Thank
Dr.
you.
Karnaratna.
Let's move to the second paper. It's outcome of NAFLD and MAFLD result from a community-based prospective cohort study by Madhunil Niriyalla, Dilip Senajit Edirivira, Arunadani Kasturiya Ratna, Shamila S.T. De Silva, Anuradha Supun Dasanayaka, Arjuna Pedashan De Silva, Rotio Kato, Arunishan Patmeswaran, and Ananda Ranjit Vikramasinghe, and H.J. De Silva. Paper will be presented by S.T. De Silva. Over to you, Doctor.
Outcome of NAFLD and MAFLD results from a community-based prospective cohort study. Introduction. Non-alcoholic fatty liver disease, NAFLD, is defined by the presence of hepatic steatosis detected on imaging or histology in individuals who consume safe limits or no alcohol and who do not have a secondary cause of hepatic steatosis. NAFLD includes non-alcoholic fatty liver, which is potentially non-progressive, and non-alcoholic steatohepatitis or NASH, which is a progressive subtype that can lead to severe fibrosis and cirrhosis. Adverse outcomes of NAFLD are associated with the degree of hepatic fibrosis and being metabolically active. Metabolic dysfunction, as defined by obesity, diabetes, or other components of metabolic syndrome, is common in patients with fatty liver, regardless of alcohol use. Metabolic dysfunction-associated fatty liver disease, or MAFLD, may be a more inclusive and overreaching definition, therefore, but is redefining NAFLD as MAFLD more meaningful, especially with regard to long-term outcome? We tried to answer this question in the Ragama Health Study. The RHS is a prospective community cohort follow-up study conducted in the Ragama MOH area of the Gampaha district in 2007 and 2014. The study population at inception were adults aged 35 to 64 years, chosen by age-stratified random sampling from electoral lists. The objective of our study was to compare anthropometric and metabolic features at baseline and metabolic outcomes and fatal and non-fatal cardiovascular events between participants with NAFLD and MAFLD compared to controls after 7 years of follow-up. Methods. The target population was initially screened in 2007 and re-evaluated in 2014. On both occasions, all participants were screened with a structured interview, anthropometric indices were done, liver ultrasound and biochemical and serological tests were done. NAFLD was diagnosed on 2 out of 3 ultrasound criteria: safe alcohol consumption by Asian standards and absence of hepatitis B and C markers. MAFLD was diagnosed on hepatic steatosis in adults and overweight or obesity, that is BMI greater than 23, or type 2 diabetes defined by standard criteria, or in the absence of overweight or obesity and absence of diabetes by the presence of at least 2 metabolic risk abnormalities that are increased waist circumference, increased blood pressure, increased plasma triglycerides, reduced HDL, or prediabetes. Controls were those who had none of the 3 ultrasound criteria, no unsafe alcohol use, no diabetes, BMI less than 23, and less than 2 of the other features of metabolic dysregulation. At re-evaluation in 2014, participants were assessed for fatal and non-fatal CVEs confirmed by examination of relevant medical records. Non-responders were contacted by telephone and post. Cardiovascular endpoints were defined as fatal CVE, that is death from myocardial infarction or stroke, and non-fatal CVE, that is non-fatal MI or non-fatal stroke, coronary artery bypass surgery, and percutaneous transluminal coronary angiography. Results. In the 2007 inception cohort, there were 2,985 persons recruited. 940 had NAFLD, 990 fulfilled criteria for MAFLD, and 362 were controls. There were more women than men in all 3 groups, and the median age was similar in all 3 groups. When compared to NAFLD, MAFLD captured an additional 88 individuals of the population and lost 38, that is lean NAFLD without metabolic dysregulation. 2,148, that is 71.9%, attended follow-up in 2014. Except for fewer males attending follow-up, rest of the characteristics were similar among the inception and follow-up cohorts. In the follow-up cohort, there were 708 who fulfilled criteria for NAFLD, 735 who were classified as having MAFLD, and 255 controls. Again, there were more women than men in all 3 groups, and the median age was similar. This is the profile of participants in 2007 who did and did not attend follow-up in 2014. As you can see, they are similar. At baseline in 2007, anthropometry and metabolic traits were similar in NAFLD and MAFLD. At follow-up after 7 years in 2014, risk ratios of having new onset metabolic traits and fatal and non-fatal cardiovascular events were similar in the 2 groups, but were significantly higher in both groups compared to the controls. Characteristics of NAFLD and MAFLD in the original cohort similar in 2007. New onset metabolic features and cardiovascular events, high in NAFLD and MAFLD, similar in NAFLD and MAFLD, but very much higher than in controls. Those excluded by the NAFLD definition but captured by the MAFLD definition showed higher baseline metabolic derangements in 2007. As you can see this in this table. At follow-up after 7 years in 2014, those excluded by the NAFLD definition but captured by the MAFLD definition had higher risk of developing incident general obesity, central obesity, diabetes, and cardiovascular events compared to controls. This you can see very clearly in this table 4. So in conclusion, ladies and gentlemen, individuals with NAFLD and MAFLD had similar metabolic traits at baseline. NAFLD and MAFLD also had similar outcomes after 7 years. Those who were excluded by the NAFLD definition but captured by the MAFLD definition were at higher risk of adverse metabolic outcomes and cardiovascular events. Thus, although it was able to increase the index population by only a small proportion, redefining NAFLD as MAFLD seems to improve clinical utility. However, more evidence is required from larger, longer-term outcome studies before strong recommendations can be made to replace NAFLD with MAFLD in clinical practice. Thank you.
Now the paper is open for the discussion and the questions. You will be given 2 minutes for the questions.
What made the international authorities to change the nomenclature? Was it the evidence or the suspicion?
For a long time, there has been suspicion that NAFLD should actually form part of the metabolic syndrome. I think you're aware of the literature. For a long time, there have been a number of studies from different parts of the world coming out that NAFLD should actually form part of the metabolic syndrome definition, because a lot of people with NAFLD had a lot of metabolic dysfunction as well. So this new thinking that metabolic syndrome, metabolic derangement should form part of NAFLD has been there for a while in the world literature. Now the gastroenterology people have actually started redefining non-alcoholic fatty liver disease as NAFLD, but the clinical utility is still to be determined. So what we thought was we will apply this to data that is already available with us with the Ragaba Health study to see whether there is a clinical utility, and there does seem to be some clinical utility in using the MAFLD definition, because it identifies people at higher risk of metabolic dysregulation and higher risk of cardiovascular events.
Thank you.
In the absence of any more questions and the time constraint, let me finish and we'll start the third case.
Oral presentation number 3. Use of thiobarbituric acid reactive substances and total antioxidant capacity as potential early markers of acute coronary syndromes. Viracon SWMPW CIB, Yatavara MD-MLDK, Sivakaneshan R, Ralapanawa DMPUK. Presenter, Viracon SWMP CIB.
Good morning to you all. I am Chiran Viracon. This is my undergraduate research presentation on the topic use of thiobarbituric acid reactive substances and total antioxidant capacity as potential early markers of acute coronary syndromes. These are the presentation contents. Let me introduce what are acute coronary syndromes. Acute coronary syndromes are a collective term for defining the ST elevation myocardial infarction, unstable angina, and non-ST elevation myocardial infarction. Acute coronary syndromes are considered as an absolute medical emergency owing to its high mortality and morbidity. The chest pain is the most common presenting symptoms among the patients. In this diagram, it shows fully occluded thrombus in coronary artery resulting in STEMI. The STEMI characterized by increased biomarker levels such as troponin I, troponin T, and there is a characteristic ST segment elevation present in the ECG. When we consider NSTEMI and unstable angina, those are present similar in the ECGs with no ST segment elevation present. And in NSTEMI, there is increased biomarker levels. It was different between the unstable angina and NSTEMI. We diagnose ACS using ECGs, using biochemical testing, and using the clinical symptoms such as chest pain and chest discomfort. When we consider the disease status, it has ACS has high prevalence and mortality rate in the developed countries. The global burden of ACS has shifted towards the underdeveloped countries recently. The early diagnosis of the ACS cases are crucial because the damage to the myocardium is irreversible. We had a general objective to assess the contribution of oxidative stress to ACS using these two parameters as early markers of oxidant stress. We had specific objects to describe the significance of these two parameters in excluding non-ACS cases, and to interpret the changes of these two parameters in categorizing ACS cases, and to forecast the significance of these two parameters as independent early predictors of ACS events. This was an analytical cross-sectional study conducted in Clinical Biochemistry Research Laboratory of the Department of Biochemistry, Faculty of Medicine. The study population consisted of all the patients presented to medical ward at the teaching hospital Peradeniya with the chest pain and chest pain equivalents. We included the clinically diagnosed ACS cases as our case group, and healthy individuals with no history of ACS events as our study group. We excluded the persons who are having antioxidant drugs as our case study group and the case group. We used the convenient sampling methods to recruit 81 participants. The case group consisted of 51 participants and the control group consisted of 30 participants. We use a simple spectrophotometric methods to analyze these two parameters. We use the SPSS for the statistical analysis. We used a test for normality. We used independent sample t-test and ANOVA with post-hoc modification for the parametric test. And we used Mann-Whitney U and independent samples KW test for non-parametric test. A p-value of less than 0.05 was considered significant. These are the baseline characteristics of our study sample. As you can see, there are significant difference among the proportions of the three ACS groups. When we consider the thiobarbituric acid reactive substances concentration, it was highly elevated in the case group over the controls. When we consider the T-bars concentration within the two dangers, both the male and female groups having significantly decreased T-bars concentrations. T-bars increases in the order of NST elevation myocardial infarction, ST elevation myocardial infarction, and unstable angina. When we compare the three subtypes, there was no significant difference among these three subtypes, but we can distinguish the controls and these three subtypes using T-bars method. The sensitivity of the T-bars assay was 88%, and the specificity of T-bars assay was 66%. When we consider TAC assay, there was significant elevation in the controls over the cases. TAC has a sensitivity of 68% and 66% specificity. When we consider gender-wise, both the male and female controls having elevated levels of TAC. When we compare between the three subtypes of the ACS, we can only distinguish the unstable angina among the controls. The TAC increased in the order of unstable angina, ST elevation MI, NST elevation MI, and the controls. Previous studies had found remarked differences between the cases and controls in the both two assays. Our study also found the marked difference in these two assays between the cases and controls, but previous studies have failed to categorize these three subtypes using these two assays. Our study was also similar to the previous findings. When we conclude this study, TAC and T-bars parameters have higher utility in excluding the non-ACS cases. There is need to evaluate these parameters using sensitive parameters, sensitive methods like HPLS and ELISA. Both the parameters can utilize for differentiating unstable angina cases from the controls. There was some limitations for this study, a smaller sample size and the different proportions among the ACS3 subtypes. These are the references of this study. I like to thank my chief supervisor, Professor Uday Ralavana, for all the things.
Okay, now paper is open for discussion. So what is the price of this? How much will it cost?
It differs among the two parameters. The TAC will cost around 300 and T-bars assay for one test, it will cost around 250 rupees.
There's no more questions. Thank you very much.
Thank you for having me here.
Ladies and gentlemen, let's get on to the fourth pre-paper. It is psychological impact of COVID-19 on the healthcare workers at a tertiary care hospital in Sri Lanka. By Baminiwatta A, De Silva ST, Hapangama A, Basnayaka BWMKE, Abevira CA, Kulasingha ADS DS, and Kaushalya SADS and Williams S. The paper will be presented by Dr. De Silva ST. Over to you.
Psychological impact of COVID-19 on healthcare workers at a tertiary care hospital in Sri Lanka. Since initial identification from China in late 2019, COVID-19 has been taking an unrelenting toll on many aspects of human life worldwide. The ever-rising number of cases and deaths announced repeatedly on media and the ensuing fear of contracting the disease have understandably placed the human population at risk of mental health sequelae. An increase in psychological morbidity has already been reported worldwide. Since the first case was confirmed in January 2020, Sri Lanka has witnessed a steady rise in the number of cases, exceeding 2,000 in June 2020, when this study was underway during the first wave. Healthcare workers are at higher risk of psychological distress as they interact with patients potentially having COVID-19 infection. Being a frontline healthcare worker is thought to be a risk factor for adverse mental health outcomes. Good mental well-being is crucial for optimal occupational and social functioning of health workers. Psychological consequences of a pandemic may persist for years after the crisis among health workers. Appropriate psychological support must be provided, therefore, to health workers, a fact approved by the WHO as well. In order to plan such strategies, it is important to gauge the prevailing nature and gravity of mental health issues among health workers in the local setting. The objectives of our study were to assess the psychological impact of COVID-19 in terms of depression, anxiety, and stress among frontline and non-frontline health workers at a tertiary care hospital in Sri Lanka, and to investigate associated factors for depression, anxiety, and stress among these workers. The study was a cross-sectional one conducted at Colombo North Teaching Hospital, Ragama, which is a screening center for COVID-19 in the western province of Sri Lanka. The frontline staff were defined as health workers who dealt with potentially COVID-19 infected patients being screened at various points in the hospital, as well as employees of laboratories within the hospital who ran RT-PCR tests and ambulance drivers who transported patients. Non-healthcare workers were defined as all healthcare workers, other healthcare workers employed at the hospital. The sample size was calculated using standard equation used when proportions are compared between two groups. Mental health status was assessed using the Depression, Anxiety and Stress Scale, DAS-21. This is a 21-item self-administered scale with 3 7-item subscales assessing depression, anxiety and stress separately as experienced during the past week. The DAS 21 has been translated and validated into Sinhala and Tamil. This is the DAS 21. A socio-demographic questionnaire was administered together with the DAS 21. Ethics approval was obtained and informed written consent was also obtained. Results. Of 500 healthcare workers invited to participate, 93.4% returned completed questionnaires. This comprised 244 frontline and 223 non-frontline workers. Females at 73% outnumbered males. Socio-demographic characteristics of the sample population and differences between frontline and non-frontline groups is shown in this table. The two groups differed significantly in occupation, income, and area of residence. The frontline group consisted of more doctors and supporting staff and less nurses, and there were more healthcare workers of the highest income category in the frontline group. Frontline workers were more likely to live in urban areas. Prevalence of and severity of depression, anxiety, and stress in the overall frontline and non-frontline groups is shown in this table. Prevalence of depression, anxiety, and stress among the healthcare workers in general was high at 19.5, 20.6, and 11.8% respectively. The non-frontline group showed a significantly higher prevalence of depression, anxiety, and stress compared to the frontline group. Relationship of frontline and non-frontline status with depression, anxiety, and stress after adjusting for socio-demographic factors using binary logistic regression is shown in this table. And these differences were significant on both univariate and multivariate analysis. Socio-demographic factors associated with depression, anxiety, and stress are shown in this table. Having children, higher income, and living with family were protective against depression. Being married, having children, and living with family were associated with less anxiety, and being married and having children were protective for stress. Participant perceptions of work environment, social circumstances, and coping strategies, and the associated risk of depression, anxiety, and stress in the two groups are shown in these three tables that I'm going to show you. Please look at the questions that we asked. Workplace-related perceptions, fear of contracting COVID-19 and inadequacy of PPE and the other questions we asked were significantly associated with higher psychological morbidity. Perceptions related to personal circumstances such as fear of transmitting infection to the family, discrimination experienced due to working in a COVID-19 screening hospital were associated with greater mental health burden. Among coping strategies, seeking help from family and friends and spending time productively were protective. Increase in alcohol and other substance consumption was associated with depression, anxiety, and stress. The non-frontline group were more likely to feel they were not provided with adequate PPE. They were vulnerable to contract COVID-19 in spite of PPE. They had not been provided adequate administrative and psychological support, and they had not been trained to cope with workplace changes. NFL workers had experienced greater discrimination and were more worried about loss of employment and income and were less likely to cope using the help of family and friends. In conclusion, the study reports for the first time higher depression, anxiety, and stress among non-frontline healthcare workers compared to frontline workers during this pandemic. Both frontline and non-frontline groups had higher psychological morbidity when compared to the general population of Sri Lanka. Having children, living with family, and being married and higher income appeared to be protective. Perceived lack of PPE, administrative and psychological support, and discrimination were associated with psychological outcomes. The limitations of this study were that the findings cannot be generalized to COVID-19 treating hospitals. It's a single center sample, and these are self-reported measures in a cross-sectional study and may not establish clear morbidity or causality. Thank you.
Now the paper is open for the discussion and the questions. In the absence of questions, let's move the next paper. Thank you very much, Dr. Silva.
Last paper for the day. Study on inter-hospital transfers of acutely ill patients received by emergency treatment unit, National Hospital Kandy, Bandara MGMA, Manilgama SR, Ranasinghe JC. A presenter, Bandara MGMA.
Good morning, everyone. Chairperson and Madam, and members of the panel, and ladies and gentlemen. Inter-hospital transfers of acutely ill patients need urgent attention. Experience from daytime transfers received by Emergency Treatment Unit, National Hospital Kandy. As you all know, inter-hospital patient transfer is an integral part of patient care in Sri Lanka. This is mainly to upgrade the level of patient care. And this is mainly due to lack of facilities and variability of facilities ranging from divisional hospital to tertiary care hospitals. There are only very limited number of studies done on these transfers, and majority of these studies highlight the issues related to transfer forms. My main objective of this study is to identify problems related to stabilization and patient transfer of acutely ill patients received by Emergency Treatment Unit, National Hospital Kandy. In addition to that, we wanted to analyze the adequacy of information provided by the transfer forms as well. This is a descriptive cross-sectional study conducted from March to May 2020, recruiting daytime patient transfers admitted from 8 a.m. to 8 p.m. Ethical clearance was obtained from Ethics Review Committee, National Hospital Kandy, and approved by the Board of Study in Emergency Medicine of VJM as well. Data was extracted from the transfer form and admission BHT. These are the details extracted. Details related to clinical condition prior to transfer, history of critical incidents during transfer, parameters monitored and supportive treatment during transfer, outcome of the patient, and the data was analyzed using descriptive statistics, McNemar's test, and chi-squares test. Results. There were total number of 312 patients. Out of that, 57% was male, and the mean age was 56.6, and the interquartile range was 43 to 71. Minimum age was 43, and maximum age was 95. As you all can see this graph, majority of transfers were from divisional hospitals and then from the base hospital. This also is highlight the lack of facilities in divisional hospital and base hospitals. And this table depicts the information extracted from the analysis of information extracted from the transfer form. As you can see in the highlighted area, majority, more than 98% of transfer forms had basic information like age, name, sex, BHD number. But interestingly, only about 1/6 of transfer forms had not mentioned the reason for the transfer. And this graph illustrates the reason for transfer, and you can see majority of transfers to National Hospital Kandy was for CT scans, and mainly for the CT brain. And then the next majority was for the further investigation and management. And then we analyzed the who accompanied these patients, and most significant thing is that more than 90% of these patients were accompanied only by healthcare assistant. And then we analyzed the further management of these patients after admission to ETU, and majority, that is about 39% was admitted to medical wards, and 1/3 of patients was transferred back to same hospital where they transferred from. These patients mainly transferred for CT brain, that's why they have been transferred back after doing CT and the necessary management at ETU. And then we analyzed the documentation of vital parameters. As you can see, only blood pressure was documented in above 50% of patients, and the saturation, pulse rate, and the GCS was mentioned only about very low percentage of transfers. And I would like to draw your attention to this table, as this is the most important finding in this study. We analyzed the vital parameters before transfer and on arrival to ETU. As you can see highlighted in yellow, those are the most significant findings. And when we analyze the patients who was on oxygen via face mask before transfer, there was 12 patients, but on admission to ETU, 21 patients needed oxygen via face mask. Then 7 patients had saturation less than 94 before transfer, but 21 patients had saturation less than 94 on admission to ETU. And then, even though there are 7 patients had bradycardia before transfer, 25 patients had bradycardia on admission to ETU. And then hypertension was noted in two patients before transfer, but 16 patients had hypertension, that is systolic blood pressure less than 90 on admission to ETU. And then next most important finding is, even though they have mentioned only 7 patients had GCS less than 8 before transfer, 20 patients had GCS of less than 8 on admission to ETU. So when we analyze these data using McNemar's test, we could see that there is significant difference, there is p-value less than 0.05, mainly in oxygen saturation, pulse rate, and GCS. According to statistical analysis, parameters before and transfer were different, and the differences were statistically significant. In conclusion, though majority provide basic information, the reason for transfer is missing in 1/6 of patients. And documentation of the clinical parameters before and during transfer is suboptimal. Deterioration of clinical parameters during transfer noted, and it warrants further evaluation with well-planned studies. And I would like to tell you some limitation of these studies. We didn't included all the transfers because of the difficulty in collecting data, and we recruited only the transfers admitted during daytime. And next limitation is we didn't analyze the comorbidities, age and sex for this deterioration of these patients. And also duration of transfer also affect this deterioration, and also monitoring facilities given by the transferring end. And in addition to that, I would like to give some recommendation depending on the study. One is we need to update and revise the current existing guidelines on interhospital transfers, as this has been last updated way back around 2002. And also we can make some departure checklists to reduce shortcomings of documentation in transfer forms. And also, as I mentioned, more than 90% patients accompanied by healthcare assistant alone, so we can create some cadre of paramedics to accompany these patients safely to reduce the deterioration of these patients. Thank you. And these are my references.
Thank you. Now the paper is open for the discussion.
What is the percentage of other category?
So, only 5% of patients accompanied by doctor, nurse, and healthcare assistant.
No, there's a category of other cause for transfers. You had,
Yeah.
right? What is the percentage of other?
Reason for transfer?
Yes.
There is about 20%.
20%?
Yes.
So if it is 20%, do you think you would have analyzed it?
Yeah.
20% of samples are in the other category. It's a huge number, it's more than 10,
Yeah.
isn't it?
About 60 patients.
Thank you very much. In the absence of questions, ladies and gentlemen, now we have come to the end of the pre-paper session. On behalf of the Sri Lanka College of Internal Medicine, let me thank all the presenters and their research groups, all the participants in person or virtually, and to our eminent judge, Professor Tilak Weeraratne, Professor in Medicine from Teaching Hospital Karapetiya, and Dr. Vasantha Disanayaka, Senior Consultant Physician from National Hospital Kandy, and my co-chair, Priyamali Jayasekara, Consultant Physician. And I kindly request you all to join for the academic program for the day, either virtually or in person, and wish all to have a pleasant day and a successful academic program. Thank you.
Good morning, everyone. You all are welcome for the first grand award round in SIMCON 2020. We have a special segment in this SIMCON 2020 called Grand Award Round, where you will be taken into different wards, and consultant and registrar will be doing a round in front of you. So for this Grand Award Round session, we have 3 eminent consultants and their registrars present here today. I would like to invite Dr. Kirti Kularatna, consultant physician from National Hospital Kandy, Dr. Kumudini Jayasinghe, consultant physician from National Hospital Kandy, and Dr. Nalayani Rajaratnam, consultant physician from Jaffna. Come over to the head table, please. Come, sit. So this is, yeah, that is the presentation, and this is web or Zoom. I'll let you know. That is the presentation. So, ladies and gentlemen, we are going to the National Hospital Kandy, Dr. Kularatna's ward. Dr. Kirti Kularatna, consultant physician, MBBS, MD, MRCP UK, FRCP London, and FCCP. Is a consultant physician in internal medicine at the National Hospital Kandy. He obtained his MBBS in 1983 from University of Peradeniya with a distinction in pediatrics and distinction and gold medal in gynecology and obstetrics. So, first 15 minutes of the grand award round will be happen at Dr. Kirti Kularatna's ward. Dr. Kularatna is here. May I invite Dr. Kularatna's registrar, Dr. Pasan Hera, to come up to the podium and present his case to Dr. Kularatna. You start.
Hello. Good morning, sir. Today our patient is, she's Mrs. X. She's a 61-year-old mother of a doctor who is a non-patient with diabetic, which is well controlled with mixed-start insulin. She has basically present with cough for 3 months duration. She complains of cough in both day and night. There was no associated sputum production, no hemoptysis, no complaints of any fever. Her examination, I couldn't reveal any abnormality in her examination. And she has been previously thoroughly investigated by the respiratory team for the similar complaint, but they couldn't arrive at a particular diagnosis on this patient.
Well, Pasan, this is not unusual. People are investigated at various places and they shift from place to place. So she has been spending about 3 months with cough in other wards. So what are you going to do? I think we'll need to take an independent history and also analyze and arrange all the investigations that are available to us. Then we got to read. We had to do internet search. And then we got to consider the conditions that are not thought of. I personally prefer to think about curable disease first. And then, after upgrading our knowledge, we retake a history, the focus history, and then re-investigate, but try not to repeat investigations that have been already done. Okay. Shall we go with the investigations?
These are basically the investigation done in the respiratory unit. Her full blood count was normal. Her ESR is elevated, which was 65 mm in the first hour. Her blood picture showing some features of infection or inflammation. She has underwent bone marrow biopsy as well, which was a reactive film. Her Coombs test was negative. Her serum protein electrophoresis was normal. And the abnormal thing found is her beta-2 microglobulin levels were elevated, which is 2648 nanograms per deciliter. And further, they have done the autoimmune screening. The ANA, anti-mitochondrial antibodies, anti-smooth muscle antibodies were negative. And tumor markers like CEA, CA125, and alpha-fetoproteins all were negative. Her thyroid profile was normal. Her UFR and urine albumin creatinine ratio was normal. And she underwent 2D echo and TOE both as well, which were not revealing any abnormality. She has underwent a MAN2, which was negative. Her sputum for AFB, culture, and gene expert all were negative. And she underwent a bronchoscopy as well, which was also a normal study. Her ultrasound scan abdomen was normal, and her liver functions were raised with raised ALT, ALP, and gamma glutamyl transferase.
So I think the most important thing is in a chronic cough is chest X-ray.
Yes.
Obviously, we can't see anything wrong in this chest X-ray. What are the report you got from the radiologist here?
Basically, they also initially thought this chest X would be a normal one, but anyway, we have discussed with the radiology team. They said there is some mild hull prominence, and maybe there may be nodularity in the hyla, but they need to proceed with the CCT chest and triple phase contrast CT liver scan for the further evaluation of the patient.
Okay.
And
shall we arrange the CCT and the triple phased?
Okay.
So basically cough, as we all know, but when the cough is more than 8 weeks, it's a chronic cough. There are a large number of causes for the cough. What are the causes of the cough? Pasan, shall we go through? Yeah, these are the causes of cough. There are a large number of causes, but these are the commonest, I suppose. I think available story and the available investigations are helping us to exclude most of these things. Possibly neoplasm, sarcoidosis, and interstitial lung remains as possibilities in this patient. So, did you take a sort of focus history, and did you find anything abnormal here? Anything?
Yes, I again inquired the patient, took a focus history, but I couldn't reveal a cause for this presentation.
Okay. So, the investigations reveal only the abnormal chest X-ray and abnormal liver functions. So, what are the causes of this multiple pulmonary nodule? Did you read about that?
Yes, sir. There are certain causes I could get through the leading to pulmonary nodules. These can be categorized into neoplasms, infections, inflammatory conditions, or either congenital conditions. Neoplasms including the primary carcinomas of the lung, secondary deposits, lymphomas, fibromas, or hematomas, and infectious conditions like TB, nocardiasis, abscess formation, round pneumonia, hydatid cyst can lead to pulmonary nodulation. And inflammatory conditions like rheumatoid arthritis, granulomatous polyangiitis, and sarcoidosis can also present with pulmonary nodules, and congenital conditions like AV malformation and sequestration can also present as in this presentation.
Okay. Can you go through the other investigations so far we have done and which are available to us?
Yes, sir. Further evaluation, she has underwent a quantiferon TB gold test, which was also negative, and her sputum culture, as PC mentioned also, it was negative. And ESR during the ward stay, and there is some rising pattern was there, 65, 98, and 102. Her CRP also marginally elevated, 18 to 15 milligrams per liter, and hemoglobin is towards low side, 11.2, blood picture showing features of infection, inflammation, and mixed deficiency. And as I have previously mentioned, her liver enzymes, our reports are also elevated. Our ones are 97 and 108 of ALT. ALP was 479 urines per liter, and gamma GT also elevated, 853. But her INR was normal, 1.02, with her serum ionized calcium level was also normal.
So, shall we go through the CECT? Was it available to us now?
Yes, sir. These are the films I got.
Yeah, but the arrow shows some abnormalities in the liver, lungs, and the spleen. But shall we go to the radiologist reporting, please?
This is the radiologist comment on the CT. There were 6 subsolid nodules in the upper lobe of the right lung, and the maximum being the 5 mm in the diameter. And there were multiple mediastinal lymph nodes as well, and multiple hypodense small scattered lesions in the liver, as well as similar sort of lesions in the spleen too. And with these radiological findings, their differential diagnosis were melioidosis or tuberculosis.
So, do you think melioidosis is likely in this patient? And because she didn't come for fever, she just came for cough.
Since the radiologist finding, though there is a very rare chance of melioidosis, I think it's good to give a trial of some antibiotic while taking the melioidosis antibody levels and culture levels. for this patient. So I thought of starting IV meropenem in this patient after taking blood cultures and miliary antibodies. But we have treated her for some time, but there was no response for the antibiotics, and blood culture was also not revealing any growth.
So cough is not getting better at all.
Better at all, yes.
Okay. So there was no response to antibiotic. So liver functions are showing abnormalities, and CT is showing liver nodules, lung nodules, and the splenic nodules. What shall we do? Shall we go for a liver biopsy?
Okay, sir. Liver biopsy was arranged actually, and it shows expanded portal tract infiltrated with lymphocytes, and there are occasional epithelioid granulomata with giant cells containing calcium spirules, no suppuration, and remaining liver tissues are normal. So the pathological diagnosis given by the pathologist was sort of granulomatous hepatitis.
So, Pasan, these liver granulomas are localized collection of inflammatory cells. It is found in 2 to 10% of liver biopsies. And it is associated with various systemic conditions and maybe incidental findings as well. There are a large number of systemic conditions like autoimmune disease, particularly sarcoidosis, primary biliary cholangitis, polymyalgia rheumatica, and vasculitic conditions. And there are large bacterial infections can cause, drugs can cause malignancies, and inherited disorders also can cause. And GI diseases are also associated with granulomatous liver conditions, and particularly metal toxicity like berilliosis and copper toxicity also spoken of. So, what are the further investigations like? Now, I think we repeated calcium, it was also normal. Then we went last with the ACE inhibitor levels, and which shows the double the normal. So, can you please summarize what we have got so far?
Basically, we got a 60-year-old female patient who presented with a chronic cough, who has been previously thoroughly investigated in the respiratory unit and found to have multiple pulmonary nodules and multiple lesions in the liver and the spleen in both imaging studies, and her MAN2 was negative and liver biopsy revealing non-caseating granuloma in the liver with associated raised angiotensin converting enzyme levels.
So, can somebody come out with a clinical diagnosis? So, if the audience is not coming out with the diagnosis, yes. So, we also thought this is sarcoidosis. Thank you very much for your suggestion. Thank you. Thank you, Pasan.
We have 4 minutes left. If anybody has any question to ask from Dr. Kuratna, you happy to take some?
Please. We started prednisolone. In fact, we handed over this patient to the respiratory units back, and they started prednisolone, and cough disappeared. She was suffering with cough, and cough disappeared. And lung functions, bronchoscopy was done, it was normal. Normal. She came with those functions, yes.
Any other other manifestation like conjunctivitis? So they get some, various.
Only the extra manifestations of the liver, spleen, granulomas, and the liver functions were abnormal. And the the bone marrow she came in, it was normal, and only this the blood picture was showing inflammation.
Is there a way, Dr. Kuratna, to differentiate pathologically the granuloma from TB to sarcoidosis?
The typical is caseation. So this caseation was not seen. We discussed with the pathologist, and he was pretty sure that there was no caseation. And if there were caseation, it would have been TB. But there's no caseation at all in this histology.
Was there any history to suggest melioidosis in this patient?
The history is not compatible with she is a sort of a housewife, and she was not attending to any field work. And the fact that there were no fever, and we haven't seen patient coming with without fever for going on only with cough.
And do they come with nodules? I heard that they come with
They
abscess,
come with
no?
abscesses. But it is only the radiologist's query. And we didn't have that in our mind.
Thank you, Dr. Kularatne and Dr. Pasan. Let me move to the next
Thank you.
case to Teaching Hospital Jaffna now. It's Dr. Nalayani Rajaratnam. She's a specialist physician in general internal medicine since 2011, currently working at Teaching Hospital Jaffna. She obtained her MBBS in 2002 and with second class honors from Faculty of Medicine, University of Jaffna, and Doctor of Medicine in 2011 from PGIM Colombo. And let me invite her registrar, Dr. T. Sanchayan, to present his case now.
Good morning, madam. I would like to present you a very interesting case for today's grand vote round. So this is a 62-year-old male. He's a farmer. He was presented with a painful swelling of the bilateral hand joints for 3 weeks duration. The pain was so intense and thus resulting in activity limiting, and it's persists in the same intensity throughout the day. There are no diurnal variations, and he also had associated right foot pain and swelling as well. And there were no, he is not suggestive of any peripheral or axial joint involvement. And patient denied any morning stiffnesses, and he also denied history of fever, malaise, or loss of appetite. His history is not significant for any diarrhea or genitourinary tract infections. Patient did not have any respiratory symptoms such as chronic cough. And he also did not notice any lymphadenopathies or any lumps or rashes or skin lesions. And he denied the history of any recent trauma, and his is not suggested for any high-risk sexual behaviors for sexually transmitted diseases. The patient is an alcohol consumer, 10 to 12 units per week, and he's a non-smoker, and there is no illicit drug abuse. And there's no contact history for tuberculosis. Travel history is not significant, and as well with the past medical, surgical, and allergy history also not significant. The patient denied any family history of the autoimmune disease or malignancy. On examination, madam, the patient was afebrile and he was not pale, anichoric, and regarding his this joint involvement, there's a asymmetrical there's a right foot angle edema is noted, and so there is no clinical evidence. There is no clinical evidence of lymphadenopathies or skin rashes, and his main complaints were these bilateral hand swelling, and on examination there was a symmetrical bilateral hand swelling with significant soft tissue edema, and his respiratory system examination is unremarkable, and cardiovascular also normal with normal blood pressure and pulse rate. And abdomen and nervous system examinations were normal, and as I mentioned earlier, there's a bilateral metacarpophalangeal joints, wrist joint, and juxtaarticular regions were very tender, and the tenderness also noted in the right angle joint as well. But surprisingly, there was no obvious joint swelling. And the predominant soft tissue edema was noted in the dorsal aspect when compared to the palm. And the patient's joint movements were diminished due to this severe pain. So these are the pictures I have taken from the patient with this evidence of.
Okay, shall we move on to the investigations what you have done so far?
This full blood count, there's a neutrophil leukocytosis, and other 2 cell signs are normal, normal hemoglobin platelet. Inflammatory markers were raised with significant rise in ESR and CRP, both. Serum electrolytes were normal, renal functions also normal. Liver biochemistry, there is no evidence of liver transaminitis. There was a mild hypoalbuminemia was there, and lactate dehydrogenase and serum ferritins. Serum ferritin is marginally elevated, and LDH is normal. Uric acid is it's in the lower side. During full report, diabetes screening were normal. Blood pressure showed there's a neutrophil leukocytosis. No other involvement of other cell lines. Serum protein electrophoresis was normal. And this is
Okay, this X-ray is, I cannot see any erosions as such, but there is significant edema noted in the soft tissues. And have you got any radiological reporting from the radiologist?
no, madam, this is not reported clinically.
Okay, shall we move on to any other investigations have we done?
Chest X-ray is normal, cardiac investigation is normal, ultrasound abdomen also, there's no significant findings. Retroviral and VDRL negative. These rheumatoid factor and anticyclic citrulline peptides were negative. ANA titers were negative. And cultures, there were no growth. Creatine phosphokinase is marginally elevated, 370. Other calcium and phosphate normal. Tuberculosis screening was normal. And we had done tumor markers as well. Prostate-specific antigen and this carcinoma CA19-9 negative. And finally, we went for this HLA typing.
So that became positive?
Positive.
Okay. So in summary, this 62-year-old previously healthy farmer presented with acute onset of painful swelling of bilateral hands and right side of foot for 3 weeks duration, but he did not have any fever or no other constitutional symptoms. And he is a moderate alcohol consumer as he was taking 12 units per week. And in examinations, actually nothing significant apart from the musculoskeletal system, which had bilateral tender metacarpophalangeal and wrist joints with edema of dorsum of both hands and dorsal surface of the right foot. And other systems were normal. And the investigations only revealed neutrophilic leukocytosis with very high inflammatory markers, but the cultures were negative. And obviously you have done the serological markers for rheumatoid arthritis, but which became negative. And HLA-B27 is positive. And so imaging, we looked for erosions, but that was not there. So I don't think that why we have brought this case to the grand round, because I don't think there is a mystery, because the first differential diagnosis is rheumatoid arthritis. If we consider the diagnostic criteria for the rheumatoid arthritis, joint involvement, this patient, though he is a 60-year-old male, he is having a symmetrical polyarthritis which involves his hands. So he's having more than 10 joints, and in which he scored 5 points, I think. And serological markers were negative, so he didn't have any scores for that. And acute phase reactions were very high. So the duration of symptoms, as he has presented with a 3 weeks history of joint pain, but as it is an evolving thing, so we may have to wait. Or at this point, as it is a 3 weeks duration. So, however, he got 6 out of 10. So, whether it is a definite rheumatoid arthritis. So, what are the other significant symptoms or signs you will look for in this patient, even though we consider the rheumatoid arthritis is a diagnosis? Yes, he is a male patient at his 60s, but that is not a against features for rheumatoid arthritis. But usually rheumatoid arthritis does not present with acute onset, because it is an insidious onset arthritis. But this patient is having an acute onset arthritis. And other thing is that they predominantly complains of constitutional symptoms like malaise, lethargic, and as you mentioned, he did not have anything, including the fever. And you said that there is no diurnal variation and there is no morning stiffness as well. And there is presence of pitting edema. Yes, rheumatoid arthritis patients, they can develop pitting edema when it is long-lasting disease with drugs such as steroids and non-steroidal anti-inflammatory drugs, or when there is a severe hypoproteinemia. So those things, at least, I think that even though the rheumatoid arthritis is high in the cards, we should consider why this patient has those signs and symptoms. Okay, so we will move on to the second differential diagnosis, that is seronegative spondyloarthritis. So reactive arthritis, I would like to consider as the ankylosing spondylitis, psoriatic, and the enteropathic arthritis are unlikely. So he's having arthritis, but usually reactive arthritis patients are coming with monoarthritis in the large joints and migratory type. And the triad of symptoms, as you know, that arthritis, conjunctivitis, and non-infectious urethritis. But there can be mucocutaneous manifestations making as a tetrad of symptoms, but those things are not there in the patient. And the duration, again, is having 3 weeks duration, but we cannot go by that. Here, this patient is having an HLA-B27 positive. And there was no history of preceding gastrointestinal or genitourinary infection. So in this case, whether we could consider the reactive arthritis, but only that he is having an arthritis, but that also that he is having a symmetrical polyarthritis. Reactive arthritis is a remote possibility, but still we would consider that. And the other differential diagnosis is an adult onset still disease. So as we see the Jamauchi criteria, fever, arthralgia, non-pruritic salmon colored rash, and the leukocytosis. So among the major criteria, so he is fulfilling the 2 major criteria as he is having the arthritis and the leukocytosis. As he is a dark complexed patient from the dark complex, so may not be appreciate the rash. So he may be having 2 or 3 major criteria. But the minor criteria, of course, he did not have sore throat, lymphadenopathy, hepatosplenomegaly, or abnormal liver function test apart from mild hypoalbuminemia. And he's having the other criteria is negative test for the rheumatoid factor and the ANA. So diagnosis of adult onset disease should be having a 5 features, and there should be a 2 major. So he's having the 2 major and 1 minor, but not the 5 features. So I don't think that adult onset still disease is on the card, and the other thing is the serum ferritin is not highly elevated. So we would consider the paraneoplastic polyarthritis. It presents with solid tumors and other hematological malignancies, and it's more in the male patients older than 50, and it is an acute onset arthritis. But clinically, there was no features which is suggestive for a paraneoplastic arthritis. So what could be the diagnosis of this patient, or whether is there anything that we could consider with all those features, and in addition to the other features, mainly the edema, and so we would consider the RS3PE, that is the remitting seronegative symmetrical synovitis with pitting edema, and it is actually a disease which earlier considered as an entity of the rheumatoid arthritis, but later on it became a different diagnosis, which comes with an acute onset of polyarthritis with pitting edema. Males are affected more, and negative rheumatoid factor with acute phase, absence of joint erosions or radiographs, and synovitis evidenced by imaging. Subcutaneous pitting edema has been undoubtedly the most characteristic pathognomonic feature. Etiology, of course, not known, but there can be association with HLA, malignancy, parvovirus, or paraneoplastic rheumatic disease. So the typical finding is the boxing glove hand in the RS3PE. Pathogenesis is still not known, but vascular endothelial derived growth factor plays a major role. And we'll move on to the treatment, and it responds well to the prednisolone with low dose, and it can give the non-steroidal anti-inflammatory drugs, so hydroxychloroquine. And prognosis is very good. And so this is after the treatment with the steroids, the patient has improved dramatically. And so why we have presented this case, even though there is a mystery, but the common conditions are common and the rare diseases are rare. Rare diseases can mimic common diseases, so always have a third eye on seeing patients with true to look. That rare diseases can be completely curable, prevent long-term treatment with toxic medications, and we can detect the underlying hidden sinister pathology early and we can treat that as well. So mysteries lie all around us, even in the most familiar things, waiting only to be perceived. So thank you, Sanjay, and thank you, Odi.
Thank you, Nalayani, for that grand order presentation. Are there any questions? We can allow one question if you have. Do you like to answer any questions? So this inflammatory arthritis, rheumatoid arthritis, at Jaffna, do you start this disease-modifying treatment as well?
Arthritis, we start not for the RS3PE, because these patients, they will very well respond to the steroids, even with the low dose steroids, and we don't continue that even for a long time. And they don't come back also. Even if they come back, we have to actively search for malignancies.
Right. Since our time is up at Jaffna, we need to move back to National Hospital Kandy. For the grand round happens at Dr. Kumudini Jayasingha's ward. Dr. Kumudini Jayasingha, MBBS, MD, and FRCPE, Edinburgh, is a consultant physician currently working at the National Hospital Kandy. She is a trainer and examiner for undergraduates and postgraduates in Sri Lanka. She holds the position of the Honorary Treasurer of Sri Lanka College of Internal Medicine, Honorary Joint Secretary of Hypertension Research Center, University of Peradeniya, and she is an Executive Committee member of Hypertension Society of Sri Lanka. So her registrar, Dr. Kitmini L.A. Pola, will present the case. Over to you, Kumudini.
Good morning, madam. Today we have a young girl who presented to us with a history of fever and altered level of consciousness for grand round. So with regards to the history, she's a 14-year-old previously healthy female who got admitted to us with a history of high-grade fever for 5 days and altered level of consciousness for 2 days. And with regards to the fever, it was a high-grade intermittent fever which was associated with arthralgia, myalgia, nausea and vomiting. And she also had generalized headache, but there was no photophobia, phonophobia or retroorbital pain. Initially, she was well in between fever spikes, but 3 days later, she developed an altered level of consciousness, but there was no history of seizures or other focal neurological deficits. There was no reduction of the urine output or other urinary symptoms, and she also denied of any respiratory symptoms, and there were no diarrheal episodes prior to the onset of fever. She also had developed anemic symptoms over 5 days prior to admission, but there were no apparent bleeding manifestations. And interestingly, she admitted of a significant non-scarring alopecia over 3 months duration with no associated oral ulcers, photosensitive rashes, or inflammatory type joint pain or swelling. There was also no history of Raynaud's phenomenon, no arterial or venous thrombosis. There was no significant family or drug history, and she had a very good family support. And on examination, she was an average level female with a BMI of 18. She was drowsy, disoriented with a GCS of 14, and she was febrile. And of note, there was no neck stiffness, the Koenig sign was negative, and she was moderately pale. And there were no other features of connective tissue disorders also. With regards to the cardiovascular system, she was a bit tachycardic, but otherwise the cardiovascular, respiratory, and the abdominal examinations were normal. And with regards to the nervous system examination, it was also normal, but we were not able to elicit sensory and cerebellar signs because of the drowsiness.
Okay, what are the possibilities that you considered in this patient, Kitmini?
Madam, since she presented to us with a history of fever and altered level of consciousness, we first thought whether this was a cerebral infection, whether this was meningitis or encephalitis.
How do you explain the presence of anemia and the alopecia with the cerebral infection alone?
Yes, madam. We also thought of the possibility of an underlying autoimmune disorder in this patient and thought whether this was a dual pathology. And since she's a fairly young female, come in with a significant non-scarring alopecia as well as neurological involvement and anemia, we also thought of the possibility of systemic lupus erythematosus here, which is complicated with cerebral lupus and hemolytic anemia. And since there's presence of fever, neurological abnormality, and clinical evidence of anemia, we also thought of the possibility of thrombotic thrombocytopenic purpura here. And of course, lower down in the list, we also thought of the possibility of hemolytic uremic syndrome.
Okay, good. How did you investigate this patient?
So, keeping our differential diagnosis in mind, we sent the basic investigations and we traced the full blood count and the blood picture immediately. And these are the results, as you all can see. The full blood count showed a significant bicytopenia. There was a hemoglobin level of 4.2 and the platelet count was also low. It was 8,000 with the blood picture evidence of microangiopathic hemolytic anemia. And the LDH count was also high. It was over thousands. And we also traced the other investigations as well. The retic count was also high. DAT profile was negative. ESR was high for her age. And CRP was normal. And the serum creatinine was marginally elevated. Liver function test showed mild indirect hyperbilirubinemia. Clotting profile was normal. D-dimer was negative. And the UFR showed no albuminuria, madam.
Okay. What is your diagnosis and how did you manage this patient?
So, depending on the clinical scenario and the investigation findings of full blood count, the blood picture, and the high LDH level, we made a presumptive diagnosis of thrombotic thrombocytopenic purpura, madam. And keeping that diagnosis in mind, we straight away went ahead with the therapeutic plasma exchanges, and she was also started on oral prednisolone as well. And we continued 7 cycles of daily total plasma exchanges with marked improvement of the hematological parameters. The platelet count improved to more than 150,000, the hemoglobin stabilized, and the blood picture showed resolving MAHA. But unfortunately, there was no improvement in her sensorium, and she was found to be in a persistent confusional state.
Okay, let's see what is TTP is like. It's a rare and life-threatening thrombotic microangiopathic kidney, and its cause is deficient activity of ADAMTS13 protease, usually an acquired autoantibody, but rarely in an inherited gene mutation. Actually, the TTP when it is full-blown, it's a pentad. They are presenting with microangiopathic hemolytic anemia, thrombocytopenia. Usually, the platelet count is less than 30,000, like in this patient. Neurological abnormalities could vary from confusion to the focal neurological signs. The fever and the renal diseases are the other two. The important thing is in the TTP is the neurological involvement is more than the renal disease involvement. Whereas in the hemolytic uremic syndrome kidney, the renal involvement is more than the neurological manifestations. Okay? So let's see the treatment modalities. As you said, the plasma exchange is the most important thing that will normalize the hematological parameters and also the organ injury. According to the other adjuvant therapies that we can give is the corticosteroids, rituximab and the calcicimab. But the calcicimab is not available for us. So why didn't you start this, the steroids and also the rituximab you would have started in this patient when the patient was not improving?
We should have started, but we did not start because of the improvement of the hematological parameters.
Okay. Any other investigations that you did arrange this patient?
Madam, because of the presence of the non-scarring alopecia, we also thought of excluding SLE here. So we sent an ANA, which was found to be highly positive with a significant titer of 1 in 1,000. dsDNA was negative, but both the complements were low. And we also arranged a concomitant 2D echocardiogram, which showed a mild pericardial effusion. So she fulfilled the criteria for Systemic Lupus International Collaborating Clinics criteria. There were 4 clinical criteria as well as 2 immunological criteria. So depending on this, we made a clinical diagnosis of SLE and she was commenced on HCQ.
Okay, what happened to your patient?
But unfortunately, madam, on day 10 of admission, she developed a right-sided flaccid hemiparesis involving the right arm and the leg with a muscle power of grade 3. But there was no mouth deviation, no slurred speech, and the swallowing was intact. But over the next few days, it progressed up to spasticity with a positive ankle and a patella conus, and the confusion persisted. So thinking whether this was a dural venous sinus thrombosis, we straight away went ahead with an MRI and MRV. But interestingly, it showed features of acute disseminating encephalomyelitis distributed in the supratentorial regions. I hope you can appreciate the T2 hyperintensive flares distributed in the caudate and the putamen areas. And we also arranged EEG, which was showing moderate cerebral dysfunction. LP was normal apart and negative for oligoclonal bands, and viral studies was also done to exclude other possible etiologies for ADEM and TTP, and they were all negative. And anticardiolipin antibody as well as the lupus anticoagulant were negative.
Okay, Kitmi, let me know you about the ADEM. It's a fulminant demyelinating disease of central nervous system, most common in children. And approximately 30% of this ADEM can progress to multiple sclerosis. The treatment is IV methylprednisolone, and IV immunoglobulin, as well as the cyclophosphamide. How did you manage your patient?
Madam, as ADEM can also present as a neuropsychiatric manifestation of SLE, we made a diagnosis of cerebral lupus here. And she was pulsed with IV methylprednisolone, a total of 5 doses, followed by oral steroids. And we also gave IV immunoglobulin for a total of 5 doses. And there was not much of improvement in the neurological status as much as we expected. So fortnightly IV cyclophosphamide was also commenced, to which she responded well. And then neurological weakness improved with vigilant physiotherapy, and she was discharged from us after 8 weeks with normal sensorium and minimal residual weakness. And currently she's asymptomatic without hematological or neurological abnormalities and is on steroids as well as HCQ. So our final diagnosis was systemic lupus erythematosus complicated with thrombotic thrombocytopenic purpura and acute disseminating encephalomyelitis.
Okay, Kitmi, let's discuss the case now. It's a very rare manifestation of SLE patient actually, presenting for the first time with a TTP and ADEM simultaneously. So important thing is this case is the prompt diagnosis and treatment of TTP, which is life-saving. And you should not wait for the other investigations once you have some investigations like in the full blood count, blood pressure, and the LDH levels. Because the ADEM TS13 protease activity is not available for us. So Kitmi, I myself did some literature survey. There are some interesting cases actually. This is the lupus presented with microangiopathic hemolytic anemia. And this is actually TTP when it was refractory found to be having SLE. And it's about 25 cases actually in SLE patients. They have discussed the different treatment modalities, and most of the cases were treated with rituximab and the cyclophosphamide. So with a different outcome as well. This case is about the SLE patient with ADEM. And that's another case they have found that the SLE patient presenting for the first time with ADEM, the following an enteroviral infection. So in our patient, actually only the SLE, there were no other preceding infections as such. So after this literature survey, there are some pearls I want to give you all. The onset of SLE precedes TTP in the majority of cases. And however, TTP can antedate to occur simultaneous with SLE, like in our patient. So it's very important to differentiate autoimmune hemolytic anemia in SLE from TTP, because any delay in plasma exchange will increase mortality. So you have to send the Coombs test, but you should not wait for the results to start plasma exchange, remember that, because the Coombs test will be negative in TTP. So the requirement of plasma exchange could vary, because in the most of these cases, actually the requirement is more than 20 cycles. Our patient actually responded to the 7 cycles. The early use of cytotoxic agents in a severe or refractory patients results in a better outcome. So initially when the neurological features are not improving, we would have started on rituximab actually. The relapses are not uncommon. Some patients actually need prophylactic rituximab as well. So there are some take-home messages that I want to give Kitmini. You have to consider thrombotic thrombocytopenic purpura when the patient presents with microangiopathic hemolytic anemia and neurological features. And also arrange LDH as well as a blood picture in SLE patients when they are presenting with neurological features to exclude TTP. They consider SLE as a possible secondary cause for TTP as well as for ADEM. And TTP is an emergency kidney, so the prompt diagnosis and treatment can save lives because you should not wait for all the investigations to come. So it's very important for you to start early plasma exchange. That is very, very important. Okay, and more than lastly that I want to tell you, do not forget to discuss social issues as well as the disease with the family. Okay, thank you very much.
Right. Are there any questions from the audience to Kumudini's team?
Would like to ask, how do you differentiate HUS from TTP clinically?
Clinically, it's actually TTP patients will have more neurological features and their renal involvement less severe. Whereas in the HUS, the renal involvement is more than the neurological involvement, and usually HUS will preceded with a diarrheal illness as well.
What about clotting abnormalities?
Clotting abnormalities, usually there's not much difference, and both will be more or less same like the presentation.
And in TTP, Kumudini, are there two varieties, acquired and...
Yes.
So
yes.
this is
Gentle as well, because of time constraint, we did not go to that 10.
This is acquired one,
This is acquired one, yes.
I think... Yeah.
Thank you, Dr. Kumudini and the team. So over to you, Ganaka, now.
I think in the first, as the first symposium, grand old round, we discussed 3 cases showing the spectrum of diseases that we have to encounter as internists. First case was from Dr. Gulratna's chronic cough, presenting granulomatous disease presenting as a chronic cough. And he took us through all the common causes and come to this diagnosis of sarcoidosis. Secondly, Nalayani discussed the case of inflammatory arthritis to show that side of our clinical management assets. And then to finish the symposium with a patient with fever and confusion, ending up with SLE and TTP. I think we had a very fruitful discussion in this grand old round. I would like to thank all 3 speakers for their and their registrars for their excellent contribution.
My colleague, Dr. Ganaka Senaratna, to hand over the certificates of appreciation for the presenters today. First is Dr. Kirti Kularatna. Dr. Nalayani Rajaratnam. Dr. Kumudini Jayasinghe. Dr. Pasan Herat. Dr. T. Sanjayan. Dr. Kitmini Alepola. And that will thank you, Ganaka, and that will conclude the grand round.
Good morning, ladies and gentlemen. I am Dr. Umakant, my co-chair, Dr. Dayaradne. Today we are here for the first symposium of Sri Lankan College of Internal Medicine Annual Congress. Today our theme of the symposium is Neurology Update. First topic is managing a patient with a ischemic stroke. We are going to invite 3 speakers. All are virtually joined with us. First, I would like to call upon Dr. Human Homayan from USA. So before call him, Few words about Dr. Human Homayan. Dr. Homayan is a movement disorder neurologist and medical director of multidisciplinary deep brain stimulation program at University of Pittsburgh Medical Center. He completed his residency in neurology at UPMC and fellowship in movement disorder at Rush University. Prior to that, he had completed his medical training at Tehran University and postdoctoral fellowship in neuroscience at Yale University and University of Pittsburgh. His primary interest is in the chronic management of patients with Parkinson's disease and other movement disorders. His research background is in neurophysiology and neuropharmacology, and he has been contributed to multiple chapters and reviews, as well as to American College of Physicians Medical Knowledge Self-Assessment Program, MKSEP. So Dr. Homayan, over to you, but unfortunately the recording is there. He didn't come in virtually, only recording.
Hi, I'm Dr. Homa Homayun from University of Pittsburgh, and I'm happy to have the opportunity today to talk to you about management of a patient with ischemic stroke. And I want to thank the organizers for the invitation. So we start with a question. A 7-year-old man is evaluated in emergency room 6 hours after he had witnessed onset of aphasia and right-sided hemiparesis. Other than hypertension treated with diltiazem, his history is unremarkable. Blood pressure is 178 on 94, and a CT of a head is normal. Which of the following is the most appropriate step in management? Intravenous antiplace, endovascular thrombectomy, CT or MR angiography, intravenous labetalol, aspirin plus clopidogrel. So the correct answer would be CT or MR angiography. This is a patient who's presenting with acute onset of neurological deficits concerning for acute stroke, and CT of the head is normal. Therefore, the next step would be to assess the status of the large vessels using MR or CT angiography. Ischemic stroke is a rapid onset of neurological deficits caused by impaired blood flow to an area of brain. Symptoms depend on the affected arterial territory. For example, in the previous case, symptoms of aphasia along with right-sided weakness point to a obstruction of middle cerebral artery on the left side. If symptoms are of lower than 24-hour duration, it would be considered a TIA or transient ischemic attack. Mechanisms of ischemic stroke include cardioembolic causes, large artery disease, small artery disease, such as hypertension or diabetes, and cryptogenic, where the specific cause is not identified. A subset of patients with cryptogenic stroke can be embolic, and these are classified as embolic stroke of undetermined etiology or ESUS. The first step in evaluation of stroke is imaging. Usually a brain CT would be helpful. The characteristic findings on ischemic stroke on the CT are a dark area or hypodensity. In this case, we see the progression of or completion of a stroke within 24 hours. So this area of hyperdensity and some swelling and mass effect pressing the other side. In contrast, the hemorrhagic stroke or intracranial hemorrhage is often shows as a bright or hyperdense spot on the CT. In this case, this is a bleeding in the base of ganglia, most likely from hypertension, showing the area of brightness on the CT. The next step in imaging evaluation of the stroke involves MRI. This is a diffusion sequence of MRI, which has high sensitivity to acute ischemic stroke. This pattern of brightness or hyperintensity, in this case, the patchy distribution, and these images suggest acute ischemic stroke, and it's called restricted diffusion. Patients who have ischemic stroke, including all patients with TIA or acute stroke, should be hospitalized for urgent evaluation and identification of mechanism of a stroke, both for treatment and for timely initiation of secondary prevention measures. An emergent non-contrast CT of the head is the first line imaging. One of its main functions is to exclude intracranial hemorrhage. CT can also show if there is a large area of already completed stroke that will show as a hyperdensity or darkness on CT. Coagulation studies should be checked, and EKG should be obtained to evaluate for atrial fibrillation and acute coronary syndrome. And in patients, if there is a suspicion for cardiac etiology, then echocardiogram is usually updated. In terms of imaging, after a non-contrast CT of the head, the next step is to evaluate the patency of the large vessels. This is usually done by a head and neck MR angiogram or CT angiogram. In certain settings, a carotid artery ultrasonography. It should be done within the first 24 hours. Other investigations include checking for blood glucose, as hypoglycemia is an important mimic for stroke, checking oxygen saturation, comprehensive metabolic profile, CBC, and troponin level. NIH stroke scale is a standardized scale that's used for assessment of clinical intensity of the stroke. It's a recommended rating scale for acute stroke and TIA. NIH stroke scale has multiple components and assess different aspects of neuroaxis which are relevant to ischemic stroke. This include level of consciousness, orientation, the ability to follow commands, language, articulation, gaze, visual fields, motor, that is independently assessed in face, upper and lower limb, ataxia, sensory deficit, and extinction to double simultaneous sensory stimuli, which is a cortical sensory function. One of the key treatments to be considered in acute care of patients with ischemic stroke is recombinant tissue plasminogen activator, or RTPA. Use of TPA has been shown in numerous studies to improve the outcome in patients with ischemic stroke and reduce the long-term neurological deficits and long-term disability. TPA is indicated for patients with ischemic stroke within the first 3 hours after onset of the symptoms. If the onset is unknown, the time after last time patient was seen to be at baseline is considered the initiation point of the window. The use of TPA can be extended to 4.5 hours if patients are younger than 80 years, stroke severity is mild or moderate. This is defined on the imaging based on absence of a very large hyperdensity on the CT or NIH stroke scale less than 25, absence of a history of diabetes combined with previous stroke, and absence of use of oral anticoagulants. And there have been some recent studies that have looked into further extending the window of IV TPA in select number of patients based on more advanced imaging criteria. If there is a high level of blood pressure, which is not unusual in acute ischemic stroke, attempts should be made to lower the blood pressure. The threshold for administration of TPA is systolic blood pressure lower than 185 or diastolic lower than 110. IV medications such as labetalol or nitrocardipine can be used to quickly reduce the blood pressure below these levels to allow for administration of TPA. And the blood pressure then should be maintained in patients who receive IV TPA below 180 and 105 for 24 hours following thrombolytic therapy to reduce risk of intracranial hemorrhage secondary to TPA. The management of acute stroke has revolutionized within the past few years as a result of a number of studies showing the utility of endovascular therapy for these patients. This therapy is based on the realization that IV TPA is not capable of reopening the large occluded blood vessels all the time, and endovascular therapy can help to improve the outcome in a number of patients if they fit certain criteria. The imaging here on the panel A shows signs of early stroke. There's not a huge area of already completed stroke that would be seen as hyperdensity or darkness, but there are some changes, including demarcation between white and gray matter being lost, the signs of early stroke. This is a CT angiogram showing a blood vessel occlusion at the left middle cerebral artery. The patient has undergone a conventional angiogram, also confirming the absence of blood flow in middle cerebral artery. And after endovascular therapy, the blood vessel is reopened and perfusion is reestablished in the territory. Endovascular therapy includes a number of methods, including intraarterial thrombolytic administration, as well as mechanical thrombectomy and, if needed, use of some stents. Use of endovascular therapy for acute stroke is indicated for suspected large vessel occlusions. Most studies have focused on anterior circulation. This includes carotid artery, proximal middle cerebral artery, but in certain settings, other large vessel occlusions may be targeted with this form of therapy. These patients should have significant neurological deficits, but there shouldn't be already an area of large completed stroke on CT. This would be based on lower than a third of MCA and middle cerebral artery territory being affected. The rationale is the areas that already have a completed stroke, there is no benefit from reperfusion. There may be actually risk of bleeding, but if there is a large mismatch, whereas there is a larger area felt to be at risk of completion of a stroke, but only a small area shows as already completed stroke on the imaging, endovascular therapy can be helpful by establishing reperfusion. If a patient presents within the first 4.5 hours from onset, the TPA, if they're eligible, should be administered and then be evaluated, and if a candidate, proceed to endovascular therapy. There are research questions about whether skipping the TPA and directly going to endovascular therapy, given it would save time, would be helpful, and this is still being evaluated. The answer to that's not been established. Patients presenting within 4.5 to 6 hours from onset, if there are candidates, can be treated with endovascular therapy. Patients who present with within a 6 to 24-hour window, if they meet eligibility criteria, could be treated with endovascular therapy. So some pearls in the acute treatment. If the patient is unable to report the time of onset, there is no witness to the onset, TPA treatment is contraindicated. The TPA door to needle time goal is less than 45 to 60 minutes. And the phrase time is brain is an important concept. Implementation of this, shortening of the door to needle time involving all aspects of medical care, from the medics, ambulance workers, emergency room staff, is the key to get to this desired door to needle time. Large vessel occlusions in the anterior circulation and the vascular therapy is associated with improved outcome in eligible patients. The number needed to treat for recanalization of large blood vessels is 2, and for independence at 90 days is 5. So the concept of extending the window of eligibility beyond the first 6 hours has been looked at in a number of studies. The general idea of managing patients with acute stroke with thrombolytic or thrombectomy is to address a mismatch between ischemic core, which is the area of completed stroke in this picture showing on purple. This is based on diffusion sequence on MRI, and a mismatch of this with the area that is at risk or penumbra. The penumbra can be assessed both clinically based on NIH stroke scale, but also by imaging using perfusion imaging. In this case, a larger area that is at risk, and the mismatch between those two is the area of the brain at risk that can be potentially salvaged using the available treatments. And this concept of mismatch between clinical or imaging assessment of penumbra or brain at risk and imaging-based assessment of ischemic core is the main concept in extending the window of eligibility for patients in acute stroke setting. Here is a looking at functional outcomes from 2 major studies of endovascular therapy, DAWN and DIFFUSE-3 trials. And it shows the outcome of a patient in terms of modified ranking scale. The 0 is completely normal, and 6 is dead, 5 being a severe disability. So it can be seen both trials, use of endovascular thrombectomy was associated with improvement in patients who had a only mild deficit and reduction of a share of patients who have severe or moderate deficits. So there has been some, revised algorithms based on these results. One is recently published in New England. The patient presents within the time of from onset under 6 hours. They should be evaluated if they are a candidate for IV-TPA. If they are a candidate, they receive IV-TPA, then they will be evaluated for eligibility for thrombectomy. If no candidacy for TPA, directly be evaluated for endovascular therapy. They need to have a angiogram, like a CT or MR angiogram, to look at the blood vessels, and they either go directly to treatment, and if not, they may be assessed to see if they meet the criteria for extended window of IV-TPA up to 9 hours. If not, they may be eligible to receive a 21-day course of combined antiplatelet, clopidogrel plus aspirin, and if not, they may be eligible to receive aspirin within the first 48 hours. Patients who present beyond 6 and up to 24 hours, they will be evaluated for their candidacy for endovascular therapy based on the criteria in DIFFUSE-3 or DAWN trial. Usually that means based on the NIH score and the time of presentation, and if there is a mismatch between the area of a brain at risk and area of a stroke that's already completed. There are other measures that should be implemented in all patients presenting with stroke. This includes airway protection, if there is decreased level of consciousness, keeping temperature below 38 degrees, using insulin if blood glucose is higher than 150, maintaining euvolemia using normal saline. Dextrose should be avoided in these patients, and use of aspirin unless thrombolysis is planned. Patients should receive DVT prophylaxis within 24 hours. All patients evaluated for stroke should undergo swallowing assessment before feeding. And early stroke rehabilitation should be prioritized because it's been shown to improve the outcome. In terms of the management of hypertension, treatment with antihypertensives should not be started unless in a very acute setting, unless systolic blood pressure is more than 220 or diastolic more than 120. The reason is importance of avoiding hypoperfusion that can be causing additional risk for the tissue that has already been hypoperfused in acute stroke setting. These targets are in a setting if the thrombolytic therapy is not planned. As I mentioned before, if thrombolytic therapy is planned, the goal is less than 185 systolic and 110 diastolic in acute setting, and after TPA should be maintained under 180 on 105 for the first 24 hours. If there is acute coronary syndrome or aortic dissection, blood pressure should be aggressively treated. Use of a number of strategies can be helpful for secondary prevention of ischemic stroke. This includes antiplatelets. Aspirin has been shown to be helpful in this setting. Aspirin plus dipridamol has some superiority to aspirin, but increases risk of side effects such as bleeding. And clopidogrel is equivalent to aspirin plus dipridamol. Based on recent trials such as CHANCE and POINT trial, it's been shown that combination of aspirin and clopidogrel is preferred for the first 21 days after acute TIA or mild stroke. And there's an improvement in terms of reducing the number of recurrent events within a kind of early 3 weeks window. Anticoagulation is not routine in all patients with a stroke, but it's indicated if there is etiology thought to be related to atrial fibrillation or left atrial thrombus. Direct oral anticoagulants are comparable to warfarin in this respect, except for when there is a valvular disease where warfarin is preferred. Use of high-intensity statin therapy is helpful for secondary prevention of stroke, and this is regardless of cholesterol level. Hypertension should be maintained under 140 to 90 for secondary prevention, and carotid endarterectomy is indicated if there's ipsilateral stenosis more than 70%, if a patient is likely to live more than 5 years, and also should be considered if there's ipsilateral stenosis in the 50 to 69% in men who are likely to live 5 years. The benefit in this group has not been shown for women. There's no recommendation to screen general population for carotid artery disease, and carotid Brui has a poor prediction value for stroke risk, but has a prediction value for increased risk of ischemic cardiac disease. Asymptomatic patients with cardiac stenosis should receive aggressive treatment for atherosclerosis, cardiovascular disease. In terms of primary prevention of stroke, in patients who have not had a stroke or TIA before, revascularization may be considered if there is more than 80% stenosis of carotid artery or there is evidence of rapid progression of stenosis. On the condition that patient is having a low cardiovascular operative risk and complication for operations considered less than 3%. Finally, cryptogenic stroke is a group of patients. The cause of the stroke in them has not been identified. In this group, patients who have patent foramen ovale, there's been shown to be benefit for percutaneous closure of PFOs and use of aspirin for prevention of a stroke. There are scores such as ROPE score that can attribute the risk of a stroke to PFO, and patients who have a higher score are more appropriate candidates for this form of therapy. These patients should not be treated with anticoagulation, just with antiplatelets. Also in the cryptogenic stroke subcategory, patients should be monitored for atrial fibrillation, but a subset of them may be found to have paroxysmal AFib over the long-term monitoring. Optimal duration of monitoring for atrial fibrillation is unclear, but if patients thought to be high risk for embolic stroke, should consider longer, such as 30 days monitoring. Thanks again for the opportunity to talk to you today.
Thank you very much, Dr. Human Humayan. So as it was the recorded one, we move to the second topics.
Good morning. Our next topic is autoimmune encephalitis, and the speaker is Dr. Sanjay Sharma from India. Dr. Sanjay Sharma, over to you.
So thank you very much. At the outset, I am very thankful to Sri Lanka College of Internal Medicine and Professor Suranga for giving me this opportunity to talk to you about autoimmune encephalitis. And my talk has got two components, clearly two components. One is autoimmunity part of it, and second is inflammation of brain, which is encephalitis. So encephalitis is nothing but it's inflammation of a brain parenchyma, and it usually results into alteration in the sensorium. And in spite of very extensive investigation, the etiology remained unknown in 62% of the patients. Nowadays, the encephalitis is classified into two: encephalitis, which we know is caused by infective agents, and there's a loss of development in the diagnostic procedure of infective etiology. And second group is completely new, which is immune-mediated encephalitis. So when you look at the human immunity, it has got two components. One is a B cell, that is antibody-mediated immunity, what you call as a humoral immunity, and there is a T cell, which is a cell-mediated or cytotoxic immunity. Talking to you about neurological disorders, so the first group of a disorder which are discovered as autoimmune disorder in neurology is against the B cells. The classical example is the myasthenia gravis, which is a formation of antibodies against acetylcholine receptor antibody, and there is a Etel-Lambert syndrome, which is again a type of paraneoplastic autoimmune disorder due to formation of antibodies against voltage-gated calcium channels. The new set of a disorder, which is against immunity against T cells, and it is divided into two components. One is the intracellular, that's directed against a cell organelle that's like a nucleus, and these are known as onconeural antibodies. So they are usually, if you go by a prior nomenclature, it's anti-Q, anti-Mo, anti-O, and those kind of antibodies. And the completely new sets of antibodies described against a cell surface protein like NMDA, voltage-gated potassium channel, or a GABA. The basic difference between these two groups of autoimmune disorders is once you talk about intracellular, there is a complete destruction of a cell, and usually they are not responsive to immunotherapy. And once you are talking about the cell surface autoimmune disorders, usually they respond to immunotherapy, whatsoever may be underlying cause, they usually respond to immunotherapy. So one thing you have to remember, whether you are talking about an intraneural antibody or cell surface antibody, association with the malignancy is very high. And rarely NMDA receptor encephalitis, what we call as N-methyl D-aspartate encephalitis, is seen after a herpes simplex infection. Autoimmune neurology can mimic as all the clinical neurological disorders with the central manifestation as well as a peripheral manifestation. They have got a lots of psychiatric symptoms like a behavioral problem, changes in a personality, depression, anxiety, fear, hallucination, psychosis, ADHD, OCD, anorexia. These are very common element of a presentation of autoimmune disorders. They are the neurological features. They may present with the subacute dementia. So once you compare it with the acute encephalitis or infective encephalitis, that's usually acute. And here there is a subacute dementia over the period of 2 or 3 months, and this causes a memory loss. They are the movement disorders. Tics are very common, the chorea, oculogyric crisis, catatonia, Parkinsonism, rigidity, and acute dystonia. All kind of epileptic seizures are known with it, generalized, partial, myoclonus, episodes of a hiccup, myoclonic jerks of a diaphragm. Uh, Speech disorders are there, aphasia and mutism. There are several brainstem features like nystagmus, ataxia, drowsiness, lethargy, sleep inversion, stupor, and loss of consciousness. And it depends on what kind of antibody you are dealing with. Very rarely you have got nephrological syndrome like a hyponatremia, which is usually associated with the LGI1 encephalitis. And gastrointestinal symptoms are common with anti-DPPX and anti-DPP6. They present with a diarrhea and a weight loss. It's easy to remember D for diarrhea and D for DPPX and DPP6. So one of the most common presentation is that of a limbic encephalitis, which is subacute onset, rapid progression of less than 3 months. There's a working memory deficit, seizures and psychiatric symptoms, and they all suggest the involvement of a mesial portion of a temporal lobe, what we call as a limbic system. If you do MRI in this group of patients, you get a bilateral brain abnormalities of T2 weighted, fluid attenuated inversion recovery, and MRI is highly restricted to a medial temporal lobe. So limbic encephalitis is almost synonymous with a bilateral medial temporal involvement. Do a CSF, and a CSF is usually inflammatory. Inflammatory means the protein is slightly raised and there is a CSF pleocytosis. EEG may shows epileptic or slow wave activity over the temporal lobe. And you have to exclude the several other causes. This is not a single cause of limbic encephalitis. Limbic encephalitis is, apart from autoimmune disorders, is known to cause by infection. Importantly, herpes infection, neurosyphilis, Whipple, and HIV. Then you have got systemic autoimmune disorder like SLE and Sjogren's syndrome, and you can see it on a glioma rarely after as a post-ictal changes in a status epilepticus. These are the common antibodies which present with the encephalitis: NMDAR, AMPA, GABA B receptor, and LGI1 receptor. They present with the psychosis, seizures, and dyskinesia. LGI1 is very specific. It produces a facioblatal dystonic seizure, and we will see it little later. DPPX we already talked about, M-glutamate receptor and neuraxin 3A. Another common presentation that with refractory seizures, and they are refractory to conventional anti-epileptic drugs, but they do respond to immunotherapy. And at least 37% of patients with a new onset refractory status epilepticus, what you call as a NORS, they are due to autoimmune etiology. So you see the MRI of a various patient of cryptogenic NORS. It shows a bilateral lesions in the white matter, and these lesions are fairly suggestive of autoimmune origin. So in A panel, the first one is a bilateral mesial temporal involvement that was a presentation like a limbic encephalitis. They are clinical scale to predict a cryptogenic NORS in an early stage of status epilepticus. You can safely apply this scale, and if their score is above a 5 point out of a 6, then you label them as a cryptogenic NORS. First two criteria are very mandatory to diagnose this. That's 3 are required, so you need to have a 5 criteria to diagnose it as a NORS and treat it with the immunotherapy rather than the anti-epileptic drugs. Cerebellar dysfunction is seen with a multiple antibody, especially voltage-gated calcium channel. They produce with the cerebellar ataxia. There's a gate instability. Stiff person syndrome, they present with the progressive encephalomyelitis with rigidity and frequent myoclonus. It is associated with a thymoma, small cell carcinoma of lung and the Hodgkin's. And a classical example is that of a glycine receptor antibodies against a glycine receptor and amplifying receptor. Parkinsonism may happen. Symptoms like a Parkinsonism may happen if you have got antibodies against a dopamine 2 receptor. There is another one which predominantly present with the brainstem dysfunction. This is immunoglobulin LON5, which presents with the REM and non-REM sleep disturbances and other brainstem dysfunctions like drowsiness, loss of consciousness. There is a hypoventilation and other respiratory symptoms. So the first one, our journey started really in December 2003 when Joseph Dalama described this young female with ovarian teratoma. She developed a particular group of symptoms. It took months together to diagnose this patient to suffer from anti-NDA receptor encephalitis. And the classical features are seizures with a cognitive decline. There are psychiatric symptoms that present at sometimes they almost appear like a psychiatric patient in the ward. They are catatonic. There's lots of stereotype dyskinesia, autonomic dysfunction, and if you screen them with a high resolution ultrasound, you get the teratoma there. So we see a video here. Can you see a video? Can you appreciate a video? So it's a shot of oculogyric crisis. The eyeball are moving upwards. There is stereotype movements at both the corner of a mouth. And this is what typical dyskinesia in NMDA receptor encephalitis looks like. Currently, I am working against a voltage-gated potassium channel antibodies. And this is divided into two, LGI1 and a Caspar-2. So these are the two components of VGKC antibody. Once you talk about LGI1, it has got a predominantly a central manifestation with a seizures and a limbic encephalitis. When you talk about a Caspar-2, it's a more and more of a peripheral presentation with a neuromyotonia, a Moore-1 syndrome. Earlier, there was a Suck syndrome. So these are all part and parcel of a Caspar-2 presentation. So let's see a video, check a video. These seizures are very brief. You have to wait for a second to see, to appreciate. Very brief seizure, faciobrachial dystonic seizures, may be associated with the hyponatremia, may be associated with the thymoma. Just wait for a second. So now watch carefully. It's very brief, lasting for a few seconds only, for very few seconds, very brief, very stereotype, coming several times a day. And if you see this kind of a presentation, you are very sure of you are dealing with the LGI antibody, and these are typical faciobrachial dystonic seizures. So then it comes to be my topic, which is a Moore-1 syndrome. It has got a three component, a peripheral component with the muscle twitching and neuropathic pain. There are lots of autonomic disturbances, sweating, cardiac arrhythmia, constipation, central manifestation, insomnia. They just don't sleep. There's a confusion, hallucination, and sometimes they throw a seizure also. And once you do a VGKC complex antibody, Caspar-2 antibodies are present in a very high titer. And symptoms, what's the beauty of this syndrome? The symptoms and signs improve with the plasma exchange and immunosuppression. So have a look on this neuromyotonia here. There's continuous cramp fasciculation going on in a calf muscle, which is a neuromyotonia. Also it's subtle at the thigh, which you may not be able to appreciate. And surely you will see undulating movements of a toes there. So this is a neuromyotonia, Moore-1 syndrome, one of the patients from our cohort. So we see a MOVA syndrome because of multiple reasons in the Indian subcontinent. It's described with the post-escotal tap, and we described the 18 cases of this. It's described of the Ayurvedic medicines. Other history includes a polio, GBS-like presentation after Bell's palsy, partial vertebral collapse, other autoimmune disorder, nephrotic syndrome, and varicocele embolism. That brings me to GABA, and GABA has got two antibodies where it produces autoimmune disorder against a GABA A and GABA B. GABA A almost presents like a ADM. So if you are talking about a last presenter, there was a one case of thrombocytic purpura which presented with the ADM kind of presentation, and the one of the differential diagnosis in that patient is a formation of antibody against a GABA A receptor. They usually present with the refractory status epilepticus and associated with the thymoma. And there is a classical ADM like picture on MRI. There is multifocal T2 hyperintensity. On a contrast, GABA B is present with the limbic encephalitis in its status epilepticus and usually associated with the small cell carcinoma. Every week or every month, there is another description, one or another autoimmune disorder script popping in a literature. And there are several. There are more than 52 disorders, autoimmune disorders. We have touched only a few classical presentation, which I am aware, which I am dealing with in my clinical practice. So how you work this patient? This patient require a very extensive workup. You start with the serum. The mandatory thing that you have ruled out the infective part of it. There should be a no infective etiology to it. You get the serum, you get the ANA, you rule out the systemic collagen disorder, get the TPO. Although Hashimoto thyroiditis itself is a controversial topic right now, do a CSF study and look for an inflammatory response, white cell blood count, to look for other immunological markers like IgG index, oligoclonal bands. Get the MRI. MRI may show a bilateral temporal lesion or scattered white matter lesion, but usually these lesions are bilateral. EEG may show a focal spike and slowing. It's not very useful. At times, it's showed a very particular finding, which is called as extreme delta abrasion. That means superimpose faster activity on a slow activity, seen in with the NMDA receptor encephalitis. Get the PET scan done, which shows hypermetabolism, but more importantly, PET is required for a malignancy screening. You have to rule out an underlying malignancy. The extensive workup has to be done to rule out a malignancy. You do a thyroid scanning, scan a lung, breast, gut, prostate, do upper and lower GI endoscopy, and please ask to screen a testes and ovary very carefully in this group of patients. So these are the several radiological reasons. One is involving a basal ganglionic here. There are bilateral presentation here. There are certain lesions, and which are all suggestive of presence of autoantibodies. So how you ask for a sample to be tested? In a serum or CSF or pair? Our policy is to ask as many as antibody as possible and ask it both in a serum or CSF both. It may happen that sometimes it's a more sensitive in a serum or sometimes it may be a more sensitive in a CSF, but you should do it in a both CSF and a serum. And approach may be rarely very specific. You know that looks like an MDA or display encephalitis. You can just ask for an MDA antibody along with the herpes simplex antibody to cut down a cost. Or if you see or those typical fatiobrachial dystonic seizure, or you see or those typical more one kind of neuromyotonia, then you can ask for a specific antibodies. So once you ask for these antibodies, there may be a very well-defined syndrome. It may happen that the multiple antibodies are positive, or it may totally turn out to be antibody negative autoimmune encephalitis. Maybe the current tests are not possible. With the current test, it's not possible to diagnose the antibody negative autoimmune encephalitis. There may be presence of a novel neuronal or glial antibody, or CNS inflammation not be antibody mediated at all. treatment principle is very fairly simple with the biologics and availability of a immunotherapy. You start with the IV methylprednisolone for 5 days as a pulse therapy. You can go for IVIG or you can go for a plasma exchange. If there is a failure to this primary line or first line of a treatment with methylprednisolone, IVIG and plasma exchange, consider rituximab or cyclophosphamide, and then you have to maintain this therapy for 3 to 6 months to suppress this, because the recurrences are very common with this particular group of disorders. So what we do eventually in all this inflammatory CNS inflammatory disorder, whether it's a multiple sclerosis or neuromyelitis optica or autoimmune encephalitis, we target the B cells. We target the B cells, and there's interaction between the B cells and T cells, which leads into suppression of the symptoms in this group of disorders. So first line is IVIG, plasma exchange, and corticosteroids. And second line is rituximab, tocilizumab, or bortezomib, which are many biologics which are coming into a field on treatment of autoimmune encephalitis. So thank you very much for patiently listening today, and that's it from my side.
Dr. Sharma, thank you very much for your excellent lecture. As since we are behind the time schedule, there is no time for questions, and we will move to next one.
Thank you.
Yeah. So next topic is new anti-epileptics. So this is the last topic of the first symposium. I would like to call upon Professor Udaya Zenivaratne. He is already joined with us through the virtually joined with us. Professor Udaya Zenivaratne, please, over to you.
Thank you very much, and thank you for the kind introduction. And I'm delighted to be joining you today at this conference. And I wish I could be there in person, but at least the opportunity to join you virtually is such a wonderful opportunity. And first of all, I would like to thank the organizers, particularly my friend Professor Jalat, who invited me. Let me share my slides. Give me a minute. All right, so the topic given to me is new anti-epileptic drugs. So with your permission, I'm going to change it slightly to newer anti-seizure drugs. You will understand the reason at the end of my talk. During my talk, I'm going to talk a little bit about the history of anti-seizure drugs and some fundamentals, how you choose the right drug for the right patient. I will briefly touch upon some anti-seizure drug mechanisms of action. And also, finally, I will talk about some new drugs which are currently in use, and talk a little bit about future perspectives. The history. The first agent to be used as an anti-seizure agent was bromide. Incidentally, this was started by an obstetrician to treat his patients with what sounds like catamenial epilepsy. And in 1900s, phenobarbital was discovered. This was a real game changer. It's such a powerful drug. Even today, we use phenobarbital in routine clinical practice. It is still very useful in treating status epilepticus. In this story, I think the most important landmark is here. In 1975, the NINDS established what we know as anticonvulsant screening program. So that was a real watershed in this story. And after that, we saw an exponential rise in the number of anti-epileptics, as you can see here. Now we have over 40 anti-seizure drugs, and most of those drugs were added to our armamentarium over the last couple of decades. So how do we choose? There are so many drugs. How do we choose the right drug for the right patient? So let's look at some fundamentals without going too much into details. when we choose an anti-seizure drugs, I think the first question we need to look at is the seizure type. You need to choose the drug which fits the right seizure, whether it's a myoclonic seizure or an absent seizure or a generalized tonic-clonic seizure. You have to think about that before we choose the drug. And with that comes the epilepsy type and the epilepsy syndrome, which is important. You know, what we choose for a generalized epilepsy may be different from what we choose for a focal epilepsy. I'll quickly look at that in the next couple of slides. The sex of the patient is important, particularly in women. We are looking at problems with pregnancy. If you're starting a medication, you have to think about teratogenic side effects. If the woman is going to get pregnant, there may be some interactions with contraception. That's something to think about. And there are implications on menstrual cycles. So choosing an anti-seizure drug in a woman, there are a number of questions to ask, and it can be quite different from what you choose in a male, for instance. The age is important. As you know, with the pharmacokinetics change with age, and elderly people may be on multiple medications, so you have to look at that aspect. Ethnicity can be important in some situations. One good example is carbamazepine-induced allergic reactions. You may have heard of this HLA typing. HLA-B1502 is associated with severe allergic reactions in Asians when treated with carbamazepine. So ethnicity is an important consideration in some situations. Cost, of course, is applicable everywhere in the world. You can prescribe a medication, but if the patient can't afford it, there's no point giving a prescription. Comorbidities, if the patient is having multiple medical conditions, you have to think about it. For an example, if the patient suffers from severe depression, am I going to prescribe levetiracetam, where it might exacerbate depression? So that has to be considered. Another example is morbidly obese patient. Am I comfortable prescribing sodium valproate because weight gain is one of the side effects? So it's another important consideration. And drug interaction, of course, patients may be on multiple other medications. So you have to consider the interactions, which might have bidirectional effect. Your anti-epileptic may not be very effective. And at the same time, it might render the other drugs less effective. So that, again, you have to take into consideration. So I mentioned briefly about epilepsy classification. This is an important thing to consider when you choose the drug. Broadly speaking, we have two major groups of epilepsies. We have generalized epilepsy and focal epilepsy. In generalized epilepsy, we are talking about epilepsies characterized by bilateral epileptic networks. In focal epilepsy, they are very isolated, very small networks, often unilateral. So in generalized epilepsy, the first line drug is still sodium valproate. It works really well in multiple seizure types, quite effective for myoclonus, absences, generalized tonic-clonic seizures, all seizure types. Unfortunately, there is a serious risk of teratogenicity, so you have to think twice before we prescribe this to a female of childbearing age group. So in those patients, there are second-line drugs we may consider, like lamotrigine, topiramate, levetiracetam, sonizumab, and perampanel as second-line drug. Out of those, the drugs with least teratogenic risk would be lamotrigine and levetiracetam. In focal epilepsy, essentially, you can use any of the anti-epileptic drugs available. The first line often is carbamazepine, lamotrigine, and levetiracetam. And second line drugs, there are lots of other anti-seizure drugs available as second line. It's important to remember, sometimes we treat patients with drugs with the hope it will make the situation better, but there are situations our drug might actually make the situation worse. One good example is worsening of myoclonic seizures and absent seizures in generalized epilepsies by certain drugs, such as carbamazepine, phenytoin, and oxcarbazepine, phenobarbital. This group of drugs can make myoclonic seizures and absent seizures worse. That's why the seizure type and epilepsy type is very important when you choose the drug. So you wouldn't use carbamazepine and phenytoin in someone with generalized epilepsy with myoclonic seizures and absent seizures. let's briefly look at anti-seizure drug mechanisms. This is not absolutely necessary for you to know when you're choosing a drug, but I think it is helpful if you understand the mechanisms of action, particularly if you are trying to combine drugs. It's always helpful. If there are any medical students in the audience, they might be more interested in this. So I generally see this as a warfare between the good guys and the bad guys. So some neurochemicals are excitatory, and those chemicals make us more vulnerable to seizures. On the other hand, there are other drugs which have there are other chemicals which have the opposite effect. So good guys are GABA and potassium channels. So these drugs, these agents are neuroinhibitory. So if you want to stop seizures, you have to help these good guys. So you have to give GABA agonists or GABA enhancing drugs and open up potassium channels. So to stop seizures, you have to stop the bad guys. So these are all excitatory neurotransmitters and receptors. You have to block these guys. So you have to give drugs which blocks glutamate, AMPA blockers, NMDA blockers, and block the sodium channels and block calcium channels. So that is very, very simple summary of the mechanisms of action. This is a very basic cartoon showing you, these different modes of action. Just lining up, you can see on the left-hand side of your screen all the good guys, and on the right side of the screen all the bad guys. So you have to block these bad guys and help the good guys on your right side of the screen. It's too basic to remember, but let's look at some examples. One of the very common mechanisms used in drugs, in anti-seizure drug, is sodium channel blocking. So there are two ways you can block a sodium channel. It's a fast blocking. The examples are phenytoin carbamazepine. These are old drugs, and new drugs such as oxcarbazepine and lamotrigine. They are also fast sodium channel blockers. The other way you can block a sodium channel is what's called slow inactivation. One good example is one of the latest drugs, or one recent drug, lacosamide. It's a slow blocker of sodium channels. Then you have GABA. As I mentioned, GABA is a good guy, so you have to help GABA. So GABA agonists are sodium valproate benzodiazepines, gabapentin, and targabine. Here you can see the GABA receptor here. The GABA is released here, so you have to either increase the release or enhance this activity at the receptor. AMPA is one of the drugs, or the most recent drug which is AMPA blocking as a mechanism of action is perampanel. So you can see here AMPA receptor sitting, glutamate comes and sits on this, and it opens up some sodium channels. So to stop seizure, you have to block this AMPA receptor. So perampanel is one of those drugs. SV2A is one of the latest mechanisms. Levetiracetam and brivaracetam uses SV2A protein binding as a mechanism. So with that information, let me take you through some of the recent anti-seizure drugs available. There isn't enough time to go through all the drugs, so I will focus on some most recent and most used drugs. These are lacosamide, perampanel, brivaracetam, cannabidiol or CBD, medicinal cannabis. There's a lot of hype around these drugs. This drug, I'll talk about that, and cenobamate. Lacosamide. As I mentioned earlier, lacosamide is a slow sodium channel blocker. So it works by slowly blocking the sodium channel. Now, this drug reaches the steady state in about 3 days. So it kicks in slowly. And it's important to know that 40% of the drug is excreted in urine, unchanged. And the rest is metabolized in liver by cytochrome P450, this isoenzyme. Therefore, the dose adjustment is needed in severe liver and renal impairment if you are using this drug. So it's important to look at the blood, see whether the patient's liver function and renal functions are normal. What are the indications? So in the pivotal trial, this drug was used as adjunct therapy and or monotherapy in focal epilepsies. So it is indicated as adjunct therapy or monotherapy in focal epilepsy or focal seizures with or without secondary generalization. So this is the standard indication. But there are some studies showing it may be helpful in generalized tonic-clonic seizures in idiopathic or genetic generalized epilepsy. So you may consider as adjunct therapy for generalized tonic-clonic seizures in genetic generalized epilepsy. And there's some anecdotal evidence for its value in status epilepticus. But remember, it is only soft evidence. We don't have any hard evidence. Contraindications, these drugs should be used carefully in patients with second and third degree AV block. In the trials, there was some indication the lacosamide increase the PR interval. So when you look at the placebo group, in any trial is the placebo group and the drug group, the lacosamide group, the ECG, in anti-epileptic drug trial, ECGs are always done as part of the trial protocol in any anti-epileptic drug trial. So there was an observation, the PR interval was increased, of course, in first degree heart block, but there were no significant side effect from that. But as a precaution, second and third degree AV block is considered to be a contraindication as a precaution. But in the clinical trials, actually, there were no patients with significant heart block. This drug generally works. Starting with the low dose, that's a standard way. Most anti-epileptics, you start low and go slow, titrate slowly up. 50 milligrams twice a day is the standard way to start this in the recommendation. I usually start with 25 BD and weekly increase to reach the maximum tolerated dose up to 200 milligram BD. But sometimes the side effects may be the limiting factor, preventing you from going up to the maximum dose. The most important thing you need to be aware of when you combine with another sodium channel blocker like carbamazepine or phenytoin, the patients because of the interaction, patients get severe side effects, neurotoxic side effects, particularly dizziness, unsteadiness. So be careful if you're using another sodium channel blocker. Other side effects are not too troublesome: headache, nausea, vertigo. They are not uncommon to any anti-epileptic agent. But the most important thing to remember, if you're combining with another sodium channel blocker, keep a close eye on the side effects. The second drug I want to talk about is perampanel. So this is one of the latest drugs. As I mentioned, it's an AMPA blocker. It works here. Metabolized in the liver by the CYP3A. It's an isoenzyme of the cytochrome C450. 30% eliminated in urine, 70% through the gut. Therefore, avoid in moderate or severe renal impairment in dialysis. So again, look at the renal functions, look at the liver functions, and avoid in severe liver impairment. What are the indications? Once again, this was trialed as adjunct therapy in focal epilepsy. Unfortunately, there aren't very many trials on generalized epilepsy. Most anti-epileptic drugs, when they are trialed, the pivotal trials are on people with refractory focal epilepsy. So it is indicated based on the trial for focal epilepsy or focal seizures with and without secondary generalization. However, subsequently, there were some other studies done in generalized tonic-clonic seizures, in genetic generalized epilepsy, and this was shown to be effective. So it is indicated as adjunct therapy in generalized tonic-clonic seizures in genetic generalized epilepsy. There has been no trials done on other seizure types like myoclonic seizures or absent seizures in generalized epilepsy. However, there is no indication, at least it doesn't worsen those seizures. So you can safely use perampanel to treat generalized tonic-clonic seizures. Contraindications, hypersensitivity like any other medication, and severe liver and renal impairment. How do you start the medication? I think the trick is to start at a very low dose. This drug has side effects. Patients often tell you the best way to avoid the side effect is start with 2 milligrams and slowly increase. Originally, I think in the trials also the recommendation was to titrate weekly or fortnightly, but personally I titrate them monthly. 2 milligram nocte. The other thing is to give the medication. I tell them take the medication before you go to sleep. Then they don't feel many side effects as it happens in the daytime. So give 2 milligrams before they go to sleep, and every month titrate up to the maximum tolerated and the maximum effective dose. You can go up to 12 milligrams, but in the trials, the majority of patients got controlled with 8 milligrams. So that's kind of the median dose you're looking at. Side effects, dizziness and sleepiness. I think in my personal experience, sleepiness is the most common side effect patients complain of. Vertigo. And one of the side effects you need to be aware of is this one: aggression, anger, irritability. The family members generally tell you, after you start the medication, he or she's a new person. It's very snappy, cranky, gets angry easily. Patients can also tell you, I get angry for no reason. It is a side effect. It definitely does happen. So if it happens, unfortunately, you might have to stop the medication. Lowering the dose might help in my personal experience. This side effect is there. Often you're looking at switching to a different medication. So this is the side effect you need to keep an eye on. Unsteadiness, blurred vision can happen, not very common. I think in my experience, sleepiness is the most limiting side effect. Brivaracetam is the next drug. It's a new mechanism here. It binds to what is called SV2A protein, and that's how it actually prevents seizures is not very well known. It is the same mechanism as levetiracetam. It's metabolized by hydrolysis, so eliminated mostly in urine. So you have to avoid this drug in patients with renal failure and who are on dialysis. This is this is very, very much less protein bound. So if you use this drug during dialysis, it gets washed off. So you have to top up if you're using this after dialysis. And you may have to adjust the dose in liver failure. You can use in mild hepatic impairment, but otherwise you have to adjust the dosage. Indication, I think it is similar to the other drugs I was discussing, focal epilepsy. It is in focal seizures with or without secondary generalization. This is a very recent drug. There has been no studies in the use of generalized epilepsy. It's only in focal epilepsy. As I mentioned, you avoid this drug in severe renal impairment. How do you start the medication? You generally start with 25 milligrams twice a day, and you fortnightly increase the dose to reach the maximum, which is 100 twice a day. Somnolence and fatigue, like any other medication, side effects, dizziness, anxiety is much less. This drug is in the same family with levetiracetam, but it has much less neuropsychiatric side effects. If you have used levetiracetam, anxiety, depression, mood swings, they are not uncommon. I think about 10 to 15% of patients experience those. With brivaracetam, it is much less. So if you have someone on levetiracetam experiencing side effects, neuropsychiatric side effects, this is an option. What we do is we switch them to brivaracetam, usually starting with 25 milligrams twice a day. So 100 milligrams twice a day of brivaracetam is equivalent to Keppra, so levetiracetam 1500 twice a day. So you can decide what you can kind of gauge what the equivalent dosage is and do a switch. And cannabidiol, I think there's a lot of hype around that. I don't know your experience. In my clinic, every clinic, I have 1 or 2 patients who come and ask for a prescription for medicinal cannabis. The reason is there's so much media hype around this topic. You may have heard of this story, this little girl called Charlotte. She had severe epilepsy due to Dravet syndrome. Her parents, started growing cannabis to treat her, and she apparently had a good effect. And so that brought so much media attention to this topic, and gradually, actually, medicinal cannabis became mainstream. It became an anti-seizure drug, and some trials were done. How does it work? Actually, it is not very well known. Probably there are multiple mechanisms, but we don't know exactly how it works. It works in some patients, not in everyone. So what is the evidence? We are scientific people. We are not guided by emotions and hype. We are guided by evidence and facts. So what is the evidence? There have been 4 randomized controlled trials in children, and those trials found actually CBD is effective in Lennox-Gastaut syndrome and Dravet syndrome. So there is a place, but it is not dissimilar to other anti-epileptic drug. The efficacy is pretty similar, but there are some selected patients who respond dramatically. So it can happen with any anti-seizure drug. So it's not a miracle. It is not a miraculous drug. It works in these conditions, and it works very well in selected patients. But in adults, we have got very limited evidence, and there has been a trial using cannabidiol gel. The results have not yet been published. The adverse events are not too bad with this CBD. Diarrhea, somnolence, they're not too bad. I have personal experience in phase 3 clinical trials using the cannabidiol gel in adults. And in my experience, they tolerate it remarkably well. And none of my patients had any significant side effects. So it is well tolerated. And it does not cause psychoactive side effects, because THC is the agent in cannabis, which gives you the high. So, this is not addictive. It is, CBD is safe to be used in epilepsy. Okay, finally, I will talk about cenobamate. This is one of the latest drugs to be approved by the FDA. And it works through the sodium channel again. It inactivates sodium channel through both slow and fast mechanisms. It is extensively metabolized by glucuronidase and oxidation. It has a variable effect on cytochromic enzymes in the liver, blocks some enzymes, enhances other enzymes. So there is an unpredictable drug, other anti-epileptic drug level increase or decrease depending on which isoenzyme is involved. Once again, it is indicated in focal epilepsies, contraindications, hypersensitivity, and familial short QT syndrome. Again, during the clinical trials, it was observed that QT syndrome was shortened in those patients treated with the drug compared with placebo. However, no patient had significant cardiac arrhythmias, but as a precaution, it is mentioned that QT syndrome is a contraindication. This drug has to be given once a day. Start with 12.5 milligrams daily, slowly increase to 400 milligrams daily is the maximum, but the average dose in the trial was 200 milligrams. So I think the most dreaded side effects is DRESS syndrome. When the trial started, there were a couple of patients with DRESS syndrome, and unfortunately one participant died. So initially the trial was stopped by the FDA, and there was a review, and then they started the trial again with slow titration. That seems to have fixed the problem. After that, the patients tolerated well. There were no fatalities. And I have personal experience again in the phase 3 trials. It works really well. I think sleepiness is perhaps the main side effect, and some fatigue. Fortunately, DRESS syndrome is extremely rare now if you titrate very, very slowly. It is a very powerful drug. I think it's going to be a very powerful drug, still not in widespread use, but I think it is going to be a very good drug based on my personal experience. So finally, let's look at the big picture. So we have lots of these new drugs, but has it changed the lives of these patients? So this is from the seminal study done by Martin Brody and Patrick Kwan. So when you have when you have a cohort of patients diagnosed with epilepsy, when you give the first drug, 47% of people become seizure-free. Then you try the second drug as monotherapy or adjunct therapy. So only 13% become seizure-free. That means there are 40% of patients left having seizures while on medication. What do? You try other medication, you try polypharmacy, multiple medications, only 4% become seizure-free. And you're left with 36% of patients. What do you do next? You change the medication, you try different things, you switch, you combine different drugs, you switch to another drug and try, various combinations. Maybe another 4% become seizure-free. Eventually, you have 30% of patients with ongoing seizures despite taking medication. We call this refractory epilepsy. Unfortunately, with the advent of all these new drugs, this picture has not changed. So Brody and Kwan repeated their study in 2018, and they found exactly the same number. So it shows with the advent of all the new drugs, the big picture has not changed. We still have drug refractory patients. It's kind of disappointing, but that's a reality. The new does not mean the best. New, is it better? Not necessarily. This study shows actually some of the old drugs work better than new drugs. For example, in generalized epilepsy, sodium valproate, very old drug, but still the winner. Valproate works better than levetiracetam and topiramate. So new drugs does not necessarily mean better. But there are advantages in these new drugs. These drugs cause less enzyme induction, they have less interactions, they're better tolerated. The patients prefer to use these drugs, better side effect profile, and more importantly, they are less teratogenic drugs, so you can use safely in women. Examples are lamotrigine and levetiracetam. So there is a place in the use of these new drugs. There are definite advantages in using these new drugs. But we should not go with the illusion that just because new drugs are there, we should write off the old drugs. There is a place for both old and new drugs. And these sentiments are reflected in this expert opinion published in Lancet Neurology. It is said, this final sentence, it sums up. It says, disappointingly, however, none of these medications appear to be more efficacious than first-generation anti-seizure medications, highlighting the need for novel strategies in epilepsy drug development. That sums up the sentiment. So that brings me to my last couple of slides, and also the reason why I changed the topic. We are talking about anti-seizure versus anti-epileptic drugs. So really what we are using today, they are anti-seizure drugs. It is symptomatic treatment. It's like giving paracetamol to someone with fever. It just brings the fever down, but it does not treat the cause of fever. It's similar to that. Anti-seizure drugs are simply anti-seizure. They are not anti-epileptic. These drugs do not change the epileptogenic process. If we have anti-epileptogenic drugs, those drugs will prevent seizures. Not only prevent seizures, they will modify the seizures and prevent all the mechanisms and prevent neurodegeneration and also behavioral and cognitive alterations, which we see very often in epilepsy. So the drive now is to look for this magic drug, anti-epileptogenic drug. But is it possible? Is it just a fantasy? We are looking for this elusive anti-epileptogenic drug. There is some hope. If you look at this diagram, on top you will see a drug called everolimus. So this is a drug used in a condition called tuberous sclerosis. As you know, tuberous sclerosis is characterized by increased cell division, causing tubers and tumors. Now, this is mediated through this complex pathway. Everolimus is a drug which blocks this pathway, blocks these enzymes and prevents the cell division. At the same time, it stops seizures. So it's an anti-epileptogenic drug. It changes the mechanism of the underlying epileptogenicity. So this gives us some hope. In future, there may be anti-epileptogenic drug. But now we have to grapple with this anti-seizure drug and make the best use of those drugs for the benefits of patients. And with that, I will end my talk, and thank you very much for your attention.
Thank you very much, Professor Udaya Senvaratne, for your excellent presentation. As we all are behind the time schedule, so we better to wind up from this first symposium. Before that, I would like to thank, behalf of SIMCON 2020, all three speakers and audience and all virtual viewers. Thank you very much. Thank you.
Good morning. Welcome to the first plenary of the conference. I would like to cordially invite Dr. Mevan Wijetunga, a proud product of Sri Lanka, to deliver his talk on rhythm disorders for the internist. He's a consultant cardiac electrophysiologist. Currently, he serves as the chair of cardiology at Altru Health System in North Dakota from USA. Over to you, Mevan.
Good morning. I'm delighted to be with you today. I'm thankful to Dr. Surangamanilgama and Sri Lanka College of Internal Medicine for allowing me to participate in the SIMCON as a faculty member. As you see, this presentation is pre-recorded. I simply did not want to take a risk of a live presentation which depends on a stable internet connection in the middle of a conference. The rules and the format of this plenary session do not allow questions from the audience. If one of you has a question or a comment, please feel free to direct it to my email, which I have given in the last slide of this presentation. And I was convened to discuss the topic of cardiac rhythm disorders for the internist. As a disclaimer, I was a full-time internist some time ago. I still remain a board-certified internist, and I hope what I share with you today will be relevant to you in some way, either in clinical practice or in an exam. I like to present 3 patients whom I have seen over the past few months. I will touch upon diagnostic pitfalls and discuss key features of management in these 3 cases from the viewpoint of an internist. The first patient is a 65-year-old female who is admitted to the hospital with acute retrosternal chest pain. She has a history of hypertension, anxiety, and schizoaffective disorder. Her medications include lorazepam, olanzapine, omeprazole, amlodipine, and vitamin C. She was found to have negative troponin levels. Her echocardiogram showed normal wall motion, and she was placed on telemetry monitoring while she was hospitalized. Initially, the patient's telemetry monitoring in hospital showed sinus rhythm and monomorphic ventricular ectopy in bigeminy. The patient was asymptomatic. House officers checked her serum electrolytes and requested cardiology consultation. Over the ensuing hours, the patient developed several episodes of non-sustained polymorphic ventricular tachycardia. This particular episode shown on this slide extended for 15 seconds. The patient was transiently unconscious during this episode. So what happened? Before discussing the cardiac rhythm problem of this patient, let's revise the terminology used in ventricular rhythm problems. When the heart is in sinus rhythm, and if the ventricle is firing independent of the sinus beats, you will see premature ventricular activity like this. The term premature is used as a ventricular complex appear earlier than the expected next sinus beat. Sometimes ventricular ectopy occur every other heartbeat, and it's called ventricular ectopy in bigeminy. This is an example of ventricular ectopy in bigeminy. If it occurs every third or fourth beat, it's called trigeminy and quadrigeminy respectively. If all ventricular ectopic beats look alike, then these ectopic beats are monomorphic. If they don't have an identical QRS appearance, then they are called polymorphic or multiform. When two ventricular ectopic beats occur in a row, it's called a ventricular couplet. When three or more ventricular ectopic beats occur consecutively, it's called non-sustained ventricular tachycardia. To be called ventricular tachycardia, the ventricular rate has to be greater than 100 beats per minute. When three or more ventricular ectopy occur in a row, and if the rate is less than 100 beats per minute, it is then called idioventricular rhythm. When ventricular beats occur consecutively over 30 seconds, and if the ventricular rate is greater than 100 beats per minute, it's called sustained ventricular tachycardia. So, ventricular tachycardia, which means the rate is greater than 100 beats per minute, can be monomorphic, as in this first top example, or polymorphic, as in the middle example. The term Torsades de Pointes refers to a particular type of polymorphic ventricular tachycardia that arise in a specific situation. Let us study what Torsades de Pointes is. Torsades de Pointes is a French expression translated as twisting points, such as what you observe when you hold a rope at its ends and create a wave. In this case, it refers to polymorphic ventricular tachycardia with twisting of QRS complexes. By twisting, we mean a change in the amplitude, that is the height, and the morphology of the QRS complexes around the isoelectric line. Beyond the classical QRS morphology, there are other features that are characteristics of Torsades de Pointes. Number one, episodes of torsades usually start with a short, long, and a short pattern of RR intervals. This means a ventricular ectopic beat followed by a compensatory pause and then another ventricular ectopic beat that usually falls close to the peak of the T wave. Number two, the term torsades is confined to those polymorphic ventricular tachycardia that occur when the baseline QT interval is prolonged. Going back to our patient who developed torsades, this is what her baseline ECG showed. We measured her QT interval at 680 milliseconds. Then we made a correction to her QT interval based on the heart rate and found the corrected QT interval at 651 milliseconds, which is significantly prolonged. Going back to her telemetry rhythm strips, we see the short, long, short sequence that initiated the episode of torsades. In this case, we have a sinus beat followed by a conducted premature atrial beat, which in turn followed by a non-conducted premature atrial beat leading to the pause. The pause is followed by a premature ventricular complex that fell on the peak of the T wave. So there is this short, long, short sequence. We also see that her baseline QT interval is long. This particular episode terminated spontaneously after 15 seconds. In other circumstances, torsades may not terminate spontaneously. This is a rhythm strip of another patient in whom there was this short, long, short sequence that initiated an episode of torsades that quickly degenerated into ventricular fibrillation and caused sudden cardiac death. What is considered an abnormal QT interval? As you all know, cardiac action potential is based on ion currents across the cell membrane. QT interval represents ventricular depolarization and repolarization. Just like any other biological parameter, QT interval has a bell-shaped distribution. Based upon the measurements in healthy adults, the upper limit of the corrected QT interval is defined as 470 milliseconds in males and 480 milliseconds in females, and this cutoff represents 99th percentile for healthy adults. For each 10 millisecond increase in the corrected QT interval, there is up to 7% increased risk of torsades. In other words, a patient with a corrected QT interval of 540 milliseconds has a up to 97% higher risk of developing torsades compared to a patient with a corrected QT interval of 440 milliseconds. It is important to note that there is no threshold QT interval prolongation at which torsade is certain to occur. For practical purposes, in clinical practice, a corrected QT interval of 500 milliseconds is considered highly abnormal. Risk factors for torsades include a corrected QT interval of greater than 500 milliseconds, use of QT prolonging drugs, particularly when more than one drug is used, heart disease that usually causes myocardial ischemia or congestive heart failure, female sex, advanced age, electrolyte disturbances including hypokalemia, hypomagnesemia, and hypocalcemia, bradycardia, and genetic predisposition. A common prototype of a patient who is at risk of torsades is an elderly female who is treated with more than one medication that could prolong her QT interval. Those who are prone to develop medication-induced QT prolongation often have an underlying genetic abnormality involving the potassium current IKR. What are the options for management for a patient like this? In an acute setting, intravenous magnesium sulfate can be used, 2 grams, irrespective of the magnesium level, and the dose can be repeated if the ventricular arrhythmia continues. The potassium level needs to be optimized to a target level of 4.5 to 5 millimoles per liter. If the baseline heart rate is slow, the drugs such as isoprenaline can be used, or temporary pacing to reduce the occurrence of short, long, short sequences. obviously we need to discontinue QT prolonging drugs. The up-to-date information regarding QT prolonging drugs can be obtained from www.qtdrugs.org, which is a very handy resource for patients as well. Then we need to treat if there's any underlying conditions such as hypoxia, myocardial ischemia, heart failure. After discharge from the hospital, we need to consider alternative pharmacotherapy, continue to monitor the patient's ECG, and even consider an evaluation for congenital long QT syndrome. The next patient is a 35-year-old male who has recently undergone multiple skin biopsies for abnormal nevi on his back. He presented with nausea, vomiting, and fever for 3 days. He had erythema and tenderness around the biopsy sites, and he complained of chest tightness. His initial troponin levels were negative, and an ECG was obtained. Most of you will agree that this ECG pattern is consistent with Brugada pattern. However, we need to keep in mind of other diagnostic possibilities, which I will discuss later in the differential diagnosis. According to current consensus, there are two types of Brugada ECG patterns. Type 1 Brugada ECG pattern refers to a concave ST segmental elevation greater than 2 millimeters in lead V1 or V2, followed by a negative T wave. Type 2 Brugada ECG pattern refers to a convex ST segment elevation greater than 0.5 millimeters in lead V1 or V2, followed by a positive T wave. Type 1 pattern is also referred to as cold pattern, and it's diagnostic of Brugada. The type 2 pattern is also referred to as saddleback pattern and is non-diagnostic but is suggestive of Brugada. According to the current consensus, the diagnosis of Brugada syndrome is based on the type 1 ST segmental elevation spontaneously or after administration of a sodium channel blocker in lead V1 or V2, and these leads can be placed in a standard position in the fourth intercostal space or a little higher level to enhance the diagnosis of this condition. To diagnose Brugada syndrome, the patient needs to have type 1 ECG pattern and one of the following: a documented ventricular tachycardia or fibrillation, syncope is suggestive of arrhythmic etiology, family history of sudden cardiac death less than 45 years age with negative autopsy, type 1 ECG pattern in family members, or nocturnal agonal respiration. Brugada syndrome is a rare genetic entity transmitted in an autosomal dominant manner. It's significantly more common in men. The presenting symptoms include syncope, seizures, nocturnal agonal breathing, or sudden death. The symptoms occur at rest, during sleep, or with fever. Symptoms often occur in adulthood with influence from sex-related hormones. It is said that the Brugada syndrome accounts for about 4 to 12% of the cases of sudden cardiac death, and the death is usually due to ventricular fibrillation. The prototype patient of Brugada is a young or middle-aged man with no previous cardiac history, presenting with syncope or cardiac arrest at rest and not associated with exercise, or with agonal nocturnal breathing. Despite the presence of a typical Brugada-like electrocardiographic pattern, we still need to be alert to the possibility of mimickers or phenocopies or phenotypes of Brugada pattern. And the differential diagnosis includes right ventricular ischemia, acute pulmonary embolism, mechanical compression of the right ventricle, occlusion of the left anterior descending coronary artery, right bundle branch block pattern, left ventricular hypertrophy, pectus excavatum, and arrhythmogenic cardiomyopathy. Brugada syndrome is prevalent all over the world. Southeast Asia has the highest prevalence, highlighted in red in this world map. According to this survey, populations in South Asian countries, including Sri Lanka, have a higher prevalence of Brugada syndrome compared to the population in Europe and America. Today, we believe that many cases of sudden nocturnal death described in various cultures in Southeast Asia are caused by Brugada syndrome. This condition of sudden unexpected death of young men in the night was known in these cultures for generations before it was described in the West. These words are quite self-descriptive. In the Philippines, Bangungot refers to nightmare or to rise and moan, describing nocturnal agonal breathing. In Japan, Pokkuri means good death without long illness. In Thailand, Lai Tai means sleep and die, and Phiam means widow ghost. In Laos, Dab Sok means nightmarish evil spirit. Anecdotally and based on the experience of my cardiac electrophysiology colleagues, there are many patients with Brugada syndrome in Sri Lanka. Currently, there is only limited published data on Brugada syndrome in Sri Lankan population. I am aware of some of the ongoing research in the country and look forward to seeing the results in the future. Brugada syndrome was first described in a systematic manner by the brothers Brugada, Pedro and Josef, in 1992. They described it as a distinct clinical and electrocardiographic syndrome with a right bundle branch block pattern, persistent ST segmental elevation, and sudden cardiac death. In 2005, I had the privilege of meeting with Dr. Pedro Brugada, who was generous in giving me his autograph. In 2015, we had him as the chief guest at the annual scientific sessions of the Sri Lanka College of Cardiology, then known as the Sri Lanka Heart Association. It goes without saying that Dr. Brugada was the highlight of the conference, and his presence created a fair amount of excitement. How do we manage our patient who was found to have a Brugada type 1 ECG pattern during a febrile episode? He was asymptomatic from Brugada viewpoint and didn't have a positive family history. I can't say there is a single correct answer to this question. After nearly 30 years of its original description, we still have open questions on the genetic substrate, arrhythmia mechanism, risk stratification, and the clinical management of Brugada syndrome. We can control the so-called modulating factors and educate the patient. They include control of fever, maintenance of satisfactory electrolyte balance, and avoidance of provocative drugs, hormones, alcohol, or cocaine. Just like in the case of long QT, a list of contender drugs can be found at www.brugadadrugs.org. We can obtain a detailed family history and screen the first-degree relatives with ECGs. The patient with a presentation like this would benefit from cardiac electrophysiology consultation for further risk stratification, and further management options in the hand of the cardiac electrophysiologist include so-called provocative testing with sodium channel blockers, long-term cardiac rhythm monitoring with close follow-up, or consider empiric treatment with quinidine or implantation of a defibrillator. Our third patient is a 60-year-old male who was hospitalized for an acute coronary syndrome. He underwent successful revascularization of the left anterior descending coronary artery. And on day number 2 of hospitalization, he suddenly developed electrocardiographic abnormalities. These are the rhythm strips from the patient, and I'll give you 5 options to choose from. Does this represent monomorphic VT, polymorphic VT, Torsades de Pointes, supraventricular tachycardia, or other? Let's see what's happening here. The correct answer is the other. This is electrocardiographic artifact or motion artifact. And let's study the ECG artifact a little bit further. This is an ECG from a 55-year-old female with a history of anxiety, panic attacks, and fibromyalgia. She has had no prior history of heart disease, and she is in hospital for sepsis. This ECG was interpreted as atrial fibrillation. At first glance, you can appreciate that the QRS complexes appear in a regular manner at a rate of 88 beats per minute. In atrial fibrillation, usually one expects an irregular QRS complex, and only in specific circumstances one gets a regular QRS complex. So the next step is to see if there's a P wave preceding every QRS. So you have to look at every beat and every lead, and then a pattern emerges. There's a P wave here and a P wave here. May not be sure, but as you go on, there is a P wave here, and you can keep moving and you see P waves. And if you look at lead V1, it's clearly a P wave here and here. So this is sinus rhythm with artifact. The question can be raised if the patient was shivering due to sepsis. This is a recent ECG in which I felt as if I was stumped by a dusra. Few weeks ago, I was reading the ECGs allocated to me for interpretation, and there were about 150 ECGs to read. I must admit that I was in a rush. I saw the undulating isoelectrical line and the irregularity of the RR interval. So I called it atrial fibrillation and moved on to read the next ECG. The following day, I received a message from a primary care physician who questioned if this 18-year-old student really has atrial fibrillation. So I took a look at the ECG again. Then I realized, in my rush, I had overlooked lead V1, where there were clear sinus P waves. The irregularity I observed was in fact due to premature atrial contractions rather than due to atrial fibrillation. I use this example to highlight that none of us seem to be immune from making a misdiagnosis. In 1999, there was a study at the University of Michigan where they described 12 electrocardiographic misdiagnosis for artifact. And 4 of these misdiagnoses were made by cardiologists, another 4 by medical house officers, 3 by emergency physician, and 1 by an electrophysiologist. And these misdiagnoses led to unnecessary interventions, including introduction of unnecessary medical therapies. Some patients underwent coronary angiography. Another patient underwent pacemaker or defibrillator implantation. Another patient blood transfusions because they thought the patient has ventricular tachycardia related to anemia. One of the key features in identifying electrocardiographic artifact is to look for the so-called notches and spikes. With the help of a caliper, and then see whether it corresponds to the RR intervals before and after the so-called or presumed arrhythmia. What are the key features in identifying electrocardiographic artifact? Does the patient have a clinical history of tremors due to hypothermia, fever, Parkinson's, essential tremor, or cerebellar tremor? Is the patient on drugs such as amphetamine, xanthines, lithium, or benzodiazepines? Is there any evidence of body movement preceding the electrocardiographic abnormality? Is there any hemodynamic impairment during the event? And do you find any normal beats in any electrocardiographic lead while this arrhythmia or this presumed arrhythmia is ongoing? Is there an unstable baseline in the ECG before and or after the event? And also, are there any spikes and notches corresponding to the heart rate in sinus rhythm? With this, I like to end my presentation, and it looks like we stayed exactly within the allocated time frame. Thank you very much for your attention. If you have any questions or comments, please don't hesitate to contact me. Thank you.
Dr. Wijetunga, thank you for your beautiful lecture where you discussed 3 scenarios. Those are important to hospitalists. And on behalf of the Sri Lanka College of Internal Medicine, I would like to thank you coming virtually and presenting that beautiful lecture. Thank you so much.
Good morning and welcome. Welcome all of you. I'm Dr. Vimal Siruluwattagi. Together with my co-chair, Dr. Priyamali Jayaseka, I would like to welcome all of you for this live session. We have, the name of the session is Staying Steady on Your Feet, Independent Age. For this symposium, we have a lineup 3 speakers, 1 joining virtually and 2 are here with us. The first speaker, Professor Sarath Lekamamasam, he is the Professor of Medicine, University of Ruhuna, and he is the incumbent president of Sri Lanka Association of Geriatric Medicine. He is going to talk to you on medication safety in older adults. Over to you, sir. Professor Lekamamasam. We can't hear.
Thank the SIMCON organizers of this year for allowing the Sri Lankan Association of Geriatric Medicine to be a part of this wonderful program. My topic is medication safety in old adults, and then the time given is just 20 minutes, so I will try to go through the basics of this topic. According to WHO 2010, 50% of medications prescribed were actually most inappropriate, were done inappropriately. And also that they observed that 50% of patients don't take medication as prescribed. And also the 50% of countries don't have a basic policy for the rational use of medications. This includes Sri Lanka. In this inappropriate use of medications, old adults are the victims of most of the time. And they suffer adverse effects due to medication. And in most of the care settings, like in emergency care, in inpatient care, and also in the ambulatory care. So these adverse drug reactions are common among old adults. Treating old adults, the clinician has to face a lot of challenges because they come with a multimorbidity and as a result of polypharmacy. And also the old adults are known to have altered the pharmacokinetics and the pharmacodynamics. Medication adherence is poor among them, and now the cost of medication, and then is they do struggle with the cost of medications without a fixed income. CAM, that is the complementary and the alternative medicine, is common among those people, and some people tend to buy drugs over the counter. So one of the major challenge for prescribing in elderly is that the elderly are actually not adequately included in clinical trials. So as a result of that, it is difficult to predict the drug metabolism among them and also possible drug effects. So most of the information come from young people, and we tend to extend that information when treating old adults, and that doesn't go all right most of the time. There are notable physiological changes that occur in the old age, and we all know that the body water content is reduced, and then in parallel there's a body fat mass is increased. And also there's a slowdown of hepatic metabolism, and also decreased renal excretion. And also there's altered responsiveness and the sensitivity of the baroreceptor reflex. So they all are common physiological changes in old age. The pharmacokinetics is not very much altered, but the pharmacodynamics is very much different in old adults. Benzodiazepine may cause more sedation, and you can have a longer period of sedation for a given dose of benzodiazepine. But sometimes it can be used for the benefit, because if you give a small dose of morphine, and then the pain relief could be longer in these people. There's no significant problem with the GI absorption of a drug, but if at all, that's usually due to drug interaction in the GIT, like antacids and iron interfering with the absorption of another drug. Also, it's possible that another disease like congestive cardiac failure to cause gut edema, and that eventually reduces absorption of medication. And a notable example is loop diuretic furosemide, and the absorption of furosemide is erratic in a patient with congestive cardiac failure due to the presence of gut edema. We all know that the distribution of a drug, the distribution of a body compartment, there is less water, and then as a result of a volume of distribution become less, and giving high concentration of the water-soluble drugs in these people. And also in older adults, there's a high fat content, and then leading to a high volume of distribution of fat-soluble drug, and causing increased half-life of those drugs. And lesser concentration of serum protein, particularly those are involved with the transport mechanism, transport of drugs, and causes a high fraction of unbound form of drug, and leading to more adverse effects. The kidney is one of the major organs that suffer in old age, and there's a reduction of kidney size and reduced renal blood flow, and also number of nephrons, and also decreased renal tubular secretion, all in all leading to low glomerular filtration rate in these people. So glomerular filtration rate decreases in a sort of, in a linear manner. There are medications which are known to cause more adverse effects among older adults, like cardiovascular medications, drugs which are used commonly, and also psychotropic and anti-seizure medications, antibiotics, anticoagulants, and also NSAIDs. These drugs cause more adverse effects, and they are also in the common use among older adults. Apart from medication, there are characteristics of older adults themselves which causes more medication-related problems. For example, those older than 85 years, and also those who have got a 6 or more active chronic disease conditions like a multimorbidity, and those with reduced glomerular filtration rate, low body weight, and polypharmacy 9 or more medications, more than 12 doses of medication per day, and also people with the previous adverse drug reactions, and those people are more prone to adverse drug reactions during treatment. What is polypharmacy? Although there's no definition, number of drugs that is agreed for a polypharmacy, and most of the people find that more than prescribing more than 6 drugs, then you have to consider the possibility of polypharmacy. Actually, the older patients, they move from clinician to clinician, and then every time they see a clinician, that there's a layer of drugs over the other drugs. So there's a multiple layers of drugs prescribed to these people, and as a result of that, they get into the problem of polypharmacy. And give an example, these all are real scenarios. A 78-year-old man with hypertension and osteoarthritis of knee joints, and was managing with the HCT, a small dose of HCT for high blood pressure, atorvastatin for the cholesterol, and also celecoxib given for a short period of time. When he had a chest pain, which was not really cardiac, and he was visited a cardiologist, and then ramipril, coenzyme Q, and atorvastatin was rosuvastatin, so 2 drugs added to his prescription. Patient was seen by orthopedic surgeon for the knee pain, and the diclofenac potassium was prescribed for 1 month, and also esomeprazole was given combined with vitamin D. So within a couple of months, patient developed ankle swelling and also breathlessness, increase in shortness of breath, and then realized that their serum creatinine has shot up from 1.02 previously, 3.25 now. Seen by nephrologist, and then furosemide was added with calcitriol, allopurinol, and also multiple vitamins. And of course, he stopped 2 painkillers. He was taking simultaneously. He came back to physician, and then he was on 11 different drugs at that time that included 2 vitamins D preparations and also 2 other vitamins. So physician revised medications, put just him on a furosemide, small dose of atorvastatin, ramipril, and a calcitriol, and a local application of salicylic acid for the knee joints. And his symptoms and the renal functions improved over a period of next few weeks. And then he was given duloxetine for the knee pain, which he tolerated all right. So he was fine afterwards. So the dangers of polypharmacy is that it leads to more and more adverse effects, and then we know that what is called drug-drug interactions. And in pharmacology, we were taught about the drug-drug interaction, how one drug would interact with another drug, but we were never introduced to what is called drug-drug-drug interaction. That is how the 3 or 4 different drugs given together and how they would interact. And that information that only one has to imagine. And polypharmacy leads to poor adherence because the prescription become more and more complicated. And also there's a cost and increased cost for the prescription, and also decreased quality of life. And the studies have shown that polypharmacy is associated with poor quality of life and also increased risk of fall, and also there's a certain amount of mortality. What's the solution? And then there are tools which can review what is called potentially inappropriate medication or potentially inappropriate prescribing. Although there are many, I just choose one and 2 because those are the common ones, what's called Beers criteria and also start criteria. Beers criteria was developed in 1991 by a USA doctor, Mark Beers. And then what he mainly concentrated was what's called inappropriate prescribing and the potential risk that can cause to the patient. And in 1991, although he had 30 classes of medication under that, and the revision in 2012, he had 53, and I'm sure it will be more than that now. Just a little idea about how the BS criteria would work. Let's say, for example, a young, say a person coming with a syncope and alpha blockers, and then recommend the rationale is that increases alpha blockers increase the risk of orthostatic hypotension, and then they say generally a recommendation is to avoid that, and also that the antispasmodic, highly cholinergic, and uncertain effectiveness, and as a result is avoid. And now the level of what is called the evidence is also given in the same document. The stop-start criteria, which was developed in the Ireland and UK, that is for the first time, and the focus on what is called the omission of medication. And so it has two parts. One is a screening tool for the older person's prescription that is that is inappropriate prescribing, and also screening tool to alert doctors right treatment. And that is, they were the first people to address this issue, that is serious omissions, and where the treatment is really indicated, but the patient is not on that particular medication. So there are 65 stop criteria, and there were 22 start criteria in the stop-start criteria. Just a little idea about that again, like let's say a loop diuretic for ankle edema given for ankle edema, which is a common complaint among older adults with no clinical signs of either hypertension or renal failure. So general advice is to stop that. And also PPI given for peptic ulcer more than 8 weeks without much evidence of ongoing symptoms. And then again, the discontinuation is indicated. On the other hand, if the patient has got acute myocardial infarction, and then, patient should be on ACE inhibitor. And if the patient is not on that, and that alert the physician saying that this is one of the necessary medication. And the same is the ACE inhibitor for chronic heart failure, and also antiplatelet therapy for diabetes mellitus if coexisting cardiovascular risk factors are present. So that alerts the physician that, this medication should be started. So it is actually on two ways, like a serious omissions is also included in the stop-start criteria. Deprescribing is how you withdraw a drug. Think about, you think about how to withdraw a drug when it is first prescribed. And there is a clinician should always remember that, when you're prescribing a drug, when you're going to stop this medication or when you're going to withdraw it. But this is something which is not being researched very much, and also is not taught for the medical students in the medical undergraduate, in the medical curriculum. And then actually we are not in that frame of mind. And we know that vast majority of adverse reactions occur during the long-term medication use. But this is not a new concept. In way back in 70s, in psychiatrists, this famous psychiatrist and said that it is an art of no little importance to administer medication properly. But what is the greater challenge is know when to suspend or altogether to omit them. So a prescribing drug does not take that much of wisdom really, but then it takes some courage and some commitment when you want to come out of drug, suspend it or omit altogether. So the physician need to have a little more courage. Stopping medication, when you come to that, you have to consider interaction with other medications and also really think whether this drug is helping the patient or is it harmful. And also, a good question to why was it started? What was the indication? And does that indication is still there, or has it disappeared? And then you can safely stop it. And also, when some drugs are above the therapeutic range, for example, something like most of the time vitamin D are above therapeutic range, and there is indication to bring them to a therapeutic range. And also consider underlying renal and hepatic insufficiency. What positive action can a clinician take? Let us say less is more, keep the prescription short, and less than 6 drugs. Assess the medication, whether they are really needed, and stop medication whenever possible. And now prioritize. You don't have to treat each and everything that the patient complains. Like if you have got a patient with congestive cardiac failure, and certainly don't try to treat the osteoarthritis at the same setting, and that can wait. Avoid under treating all adults. Like in a pain, you must take care of the pain because that is not good for somebody to be in pain. And things like systolic hypertension should not be ignored. And for example, anticoagulation, a patient with atrial fibrillation, these things should not be ignored. And Pill for each ill is a very primitive type of reaction. And that is, you need not treat every condition with a drug. And some of the conditions are benign, and particularly something like postural vertigo. And usually doctors prescribe at least 2, 3 drugs for that, but then the simple procedure can put that right, and without prescribing drugs. And also look at the whether what this particular complaint effect on the activities of daily living or the quality of life. Because when the patient come to a doctor, they always bring a package of symptoms, and then it's always better to just inquire and see how much those symptoms are troublesome and interfere with activities of daily living. If they are not involved, and then certainly a little bit of advice would help them. There are non-pharmacological interventions people can think of. I had a patient who always had a pain on the right shoulder, and then later I realized that this patient used to sleep most of the time and would sleep on that shoulder. So when I asked him to change the position, then of course it got better. Think of what is called CAM, complementary and the alternative medicine, but then always consider what are the possible safety and the drug interactions. This is a story about an 85-year-old person with hypertension, diabetes, and the recent acute coronary syndrome. Managed with atorvastatin, clopidogrel, and aspirin, dual antiplatelet with gliclazide, metformin, and telmisartan. What looked like a fairly innocent prescription, including 6 drugs. He developed a sore throat and fever. For me, what looked like on retrospective, what looked like a viral, seen by a GP, gave azithromycin. So azithromycin on top of dual antiplatelet gave him a violent GI reaction, that is gastric burning. And then same GP prescribed him PPI and antacids, and antacids made him constipated, and then gave us bisacodyl. And then he had some little diarrhea, and he developed vertigo, for which cinrosin and beta-histidine were prescribed. And then he got admitted. At the time he got confused. At that time sodium was 98 and potassium 2.8. Obviously has developed inappropriate ADH secretion. Avoid prescribing, this is what's called prescribing cascade. That is prescribing a new drug to treat an adverse drug reaction. So what they should really do is, stop or reduce of any medication. Rather than doing that, what doctors try to do is, prescribe a new drug. And then that caused what is called prescribing cascade. Is it a new problem? And every time patient comes with a new problem, think of drugs. Patient comes to bilateral ankle swelling, and then think whether it is due to a drug. And these are 2 examples that I vividly remember. And one of my patients who had diabetes, hypertension, renal disease, and patient had been investigated for a possible underlying lymphoma when the patient had generalized pruritus, and then without realizing that it's allopurinol. So patient had extensive investigations and quite costly, but the culprit was allopurinol given a couple of months ago. A 74-year-old woman with diabetes, recurrent UTI, again developed increase in shortness of breath, and then patient developed crepitation in the lung bases. Chest X-ray showed that haziness in the lung bases. Had HRCT and everything, but then realized that it was a nitrofurantoin. But if somebody was aware of that possibility, and then would have omitted that long at the very, very beginning before investigations. This is a story of a loving husband and wife, and they used to come and visit me, and from Akuras every now and then. And this is a 70-year-old husband with a diabetes and a benign prostate enlargement, and also 75-year-old wife with the hypertension and coronary artery disease. They were together and then refused to move out with their children, and they were quite independent. But then children heard that father had a fall and unable to get up, so they rushed to see. And then they next day when they came, they found not only father, my own mother had fallen, and they both had fractured their neck of femur. So they were brought in the same ambulance. On admission, husband who did not have high blood pressure had a very low blood pressure with normal CBS. The wife who did not have diabetes had the low blood sugar, and so husband died because of the hypotension, and the wife died. Husband fell because of the hypotension, and the wife fell because of hypoglycemia. And it took a little while for me to realize that this what has happened, and they had switched their medication. So what wife was taking was the medication given for the husband, and vice versa. So that can happen. So start low and go slow is a good motto to remember. Like, start one medication at a time and it has a lower dose and then increase gradually while you're monitoring the response. Is a good thing to remember. And also monitor and anticipate adverse effects and always assess the adherence. Don't think that everything that you prescribe people take, they don't take. They take only less than 50% of those medications anyway. And also, so 4 principles would be less is more. Think about drugs before you make your new diagnosis, and start low and go slow, and also assess adherence. So the 4 principles that one can remember. So in summary, you do more harm than good by prescribing more. So you have to be cautious. Always think of that, that keep the prescription short. And that is something that if you see the next time you see an older person, so make sure that, you keep the prescription short, uncomplicated and simple. And also think of alternative therapies which are available. Not only pharmaceutical pharmacologic management, there are many other things you can do. Even a simple dialogue with them, a simple conversation would sometimes help them. And also think of iatrogenic diseases in the differential diagnosis, and that possibility also need to be considered, particularly when there are newer drugs added to the treatment regime. Start low and go slow is a good thing to remember when you're treating older adults, and also assess the adherence. This I remember because it used to be in the front page of my pharmacology book when I was a student, and it secured yesterday of my disease. I died last night of my physician and by Matthew Pryor, and this was in my pharmacology book, so I will still remember that quite vividly, and a good thing to remember. So thank you.
That interesting, comprehensive talk. We'll move to the second talk of the day. Topic is frailty. May I introduce Professor Chandrika Jayasinghe. She's a professor in medicine, University of Peradeniya, and physician. Over to you, madam.
Thank you, Priyamali. Chairpersons, President of the SLCIM, and the council members, and ladies and gentlemen. I thank the Council of the SLCIM and the Geriatric Association for giving me this opportunity. My topic today is frailty, and I think you can see the picture explains what frailty can cause. Now, it's an increasingly recognized geriatric syndrome. What happens is there's precipitous decline to the stress, or the effect can be, whatever the action can be very minute action. Some very insignificant stress can cause precipitous decline in an elderly person. That is due to reduction in the reserve. We all have reserves. We all have some kind of balance, but there can be precipitous drop in that reserve and the balance. And there can be hyperinflammable state in elderly, which can contribute to this. And ultimately what happens is there is poor outcome. But what you need to remember is there is an opportunity to prevent and intervene. That is why it is important for us to know about this problem. Now, very relative effect can make an independent person all of a sudden can become a dependent person. So that is what we need to prevent. What happens is when they become frail, they have poor outcome. Their outcomes can be very, sometimes you were listening to Professor Sarath Lekamvasam, false, can cause disability, and ultimately they can be either chair-bound or bed-bound, or then they might need later on frequent hospital admissions, or even might go for long-term care. Now if you take the incidence of this frailty, Over 65, about 10% of people are frail, and it can be caught up 25% to 50% over the age of 85. And this picture shows even blowing out a candle can be a problem. You might, with the exertion, effort, you might fall down. Next minute, you are frail, you can have a broken bone. So frailty can be something like that. Why you need to identify frailty? Because it can cause poor outcome, it can cause avoidable, you can avoid these things, unnecessary harm to the person. But what you need to remember is frailty is not a static thing. Once you become frail, not that you continue to become frail, you of course can either make it worse or you can improve it. It is something like a chronic illness. It's like diabetes, Alzheimer's disease. Diabetes we can control and improve. So frailty is also something like that. But what you need to remember is you must intervene early and try to retard the progression of frailty. And you can make the person independent by doing so. Why it is important? Frail elder can be a very expensive affair. You can see the change. Frail elder, if you act swiftly, you can make him a very independent elder. Both will have to, not only the physician and the patient and the relations, all should keep this in mind. It's for the benefit of everybody. You can make him an independent person. Now, if you think how a pathway of frailty, any very simple illness, could be kind of a mental stress, infection, minor infection, fall, or some other thing can change. There can be biological impact, which can alter the physiological systems, and that will push the patient into the syndrome of frailty. With weakness, reduced performance, patient will become exhausted, and there will be reduction in the physical activity, and there can be weight loss. So ultimately, can lead to poor outcomes. These outcomes can be very dangerous, can have long-lasting effects like falls, disability, dependency. When somebody becomes dependent during old age, it's very difficult to reverse it back, and ultimately death. Now there are two broad models of frailty. One is phenotypical model, and the other one is cumulative deficit model. Phenotypical model, you describe certain features, and if you have those features, certain number of those features, you say that the patient is frail. Cumulative deficit model, you see the deficiencies that you have. These deficiencies can be in the form of illnesses, problems with activities of daily living, and mental factors, drugs that you take, so can be anything, any of the things. Number of drugs, taking too many number of drugs can be a deficit. Having too many problems can be a deficit. Inability to do certain activities of daily living, they are deficits. So there are two different models. I just want to highlight now, when you assess frailty, people think that there are two different ways you can assess either way. It is not really. Phenotypical model assesses something completely different. Deficit model assesses something completely different. Phenotypical model, they describe certain symptoms and signs. And if you have those things, more than certain number, you call it that the patient is frail. And most of the time, these people are not, in phenotypical model, you think that the person is not disabled. So disabled people are not counted. Deficit model, irrespective of whether you are disabled or not, you calculate the deficits. So really what should happen is they should be complementary to each other. So you can do phenotypical model and then follow it up with deficit model. To do the deficit model, you really need to do comprehensive geriatric assessment. Now, if you see the differences, phenotypical model, it depends on signs and symptoms, whereas the other one, diseases, activities of daily living, and result, depending on the results of clinical evaluation. Phenotypical model, you don't have to do a comprehensive assessment. You just look at the patient, few questions, you can do that. But you need to do a full comprehensive assessment, geriatric assessment, to do the deficit model. And phenotypical model, there are categories, fixed categories, but other one, you can vary the categories depending on the patient. So it's a fair number of categories, about 20 to 70 categories you can include. Number of diseases, activities, various things, whatever you think is appropriate. In fact, depending on the individual also, you can include. So it is not preset criteria. As I told you, the phenotypical model does not include disabled people, other one, even disabled people, still you can assess. And you get meaningful results, but it is not on disabled people. But mind you, you need to remember most of these people can be disabled also. So disability does not mean that they are frail. Disabled people might not be frail. But in other model, even disabled people, after doing a geriatric assessment, you can get a meaningful assessment and you in fact can follow it up. So these two can be complementary to each other. When you take the categories in phenotypical model, unintentional weight loss, one, exhaustion, that's another one. That you can ask the patient. Then muscle weakness, slowness while walking, and low levels of activity. The slowness and low levels of walking you can measure by gait speed, measuring gait speed, hand grip strength, and asking various questions regarding patient's slowness. If you say that the patient is frail, if patient meets at least 3 of the above mentioned criteria. If you think patient is not frail, if patient does not meet any of the criteria. Now, what you need to, I just want to highlight the differences between these two because most of the time people check only with one category. But now say that unintentional weight loss, without checking, doing a comprehensive assessment, the reason for unintentional weight loss, you can't say that it satisfies that criteria. It may be due to something else. Weight loss can be due to something else. Or some other, the slowness can be due to some other thing, maybe previous fracture or something. Without just observing the slowness, you can't say. So this kind of assessment will have to always come with a comprehensive assessment. Now, frailty index comes from cumulative deficit method. It comprises 20 to 70. If you do 70, you can get a very better assessment. But if you don't have time, you can condense and take important 20 measures. What you need to remember is you can't do just first contact. You can't do see whether the patient is frail or not by doing frailty index. For that, you can use phenotypical method. Those 5 things, you can see whether the patient, what I have mentioned earlier, you can see whether the patient is frail by doing those 5, and later on, you can do the comprehensive geriatric assessment and see the deficits and see whether the patient. Frailty index is always after a comprehensive geriatric assessment. What is important is you can later on follow it up. If the patient scores certain number, after several months, you put the patient on preventive measures to reduce the frailty, and you can measure. So then you can see the improvement also by doing frailty index. Okay. So I think I have mentioned this. They are not equivalent. They are two different things. Depending on the time of evaluation, they should be complementary to each other, but not two different types of assessments. I have mentioned all these things. Okay, now what other things that you need to remember is frailty can coexist with multimorbidity and disability. Multimorbidity alone does not say patient is frail. You all know that so many people have so many diseases, but they might not be frail. Again, disability does not mean that they are frail. Risk factors can be any illness, can be a very insignificant short illness or chronic illnesses, autonomic dysfunction, endocrinological dysfunction, mental problems, and even an environmental problem can make you frail. Changing the environment, parents going from their house to children's house can make them frail. It's unknown environment. So that kind of things, any minor illness can make them frail unless you take some precautionary measures. There are various frailty models depending on based mainly on those phenotypical method and deficit methods. Okay. Now, how you measure, this is phenotypical method, how you measure weight loss, that is shrinking, how you measure, then the weakness through grip strength and various other things, slowness, slow activity, you can measure them. Then frailty index is Rockwood frailty index. It is through the deficits, calculating deficits. Then there is another thing, is depending on the out of phenotypical method, again, they measure fatigue, loss of appetite, grip strength, functional difficulties. Again, it is related to phenotypical method. What you have to remember is, as a screening, it is easy. You can do first visit, but you need to always follow up with the frailty index. Then there is another thing called frail scale. Again, there they measure fatigue, resistance, ambulation, illness, how many illnesses, loss of weight, and they give certain marks. And from that, out of those marks, again, this is kind of a screening method. And what you need to remember, behavioral precursors also will play a role in frailty. Now, whether the person can adapt. Now, changing the environment. If you are poor to adapt to that environment, there will be a failure, and you can become frail. If you are unhappy, you can become frail. You can become depressed, and that can increase the frailty. So that, to some extent, your behavior, your attitudes too can have impact on frailty. Okay, so maladaptation can make you frail. Frailty can be a vicious cycle. So your family ties, social networks, when you say that when you retire, and if you are very unhappy about your retirement, if you have no plans, you become unhappy. What happens is you go on becoming unhappy, you won't make plans, you become, you don't know how to enjoy your retirement, you become frail. But if you pre-plan, you enjoy your retirement, you won't become frail. So something like that. You change the living space, you don't adapt very well, you become frail. So it's maladaptation is also a thing. So its clinical manifestations are due to the person's biological problems plus attitudinal problems, and it can self-perpetuate. So there will be underlying molecular, cellular, physiological, functional changes. There can be problems in the immune mechanism. There will be abnormal inflammation, and this inflammation will cause catabolism and skeletal muscles. There can be effects on skeletal muscles. There can be malnutrition, anorexia, loss of muscle, loss of weight. All these can contribute to frailty. Then there can be endocrinological problems with stress and all. There can be endocrine system can play havoc, and there is reduction of growth factor, testosterone, growth hormones, and increase in cortisol. All can add to frailty. Then there can be musculoskeletal system, sarcopenia, loss of muscle. And in addition to that, person might put on weight that is called sarcopenic obesity. There can be fatty muscle infiltration. There will be fatty infiltration. It's a hyperinflammatory state, and that also can add up into frailty.
Madam, you have got only less than 2 minutes.
Less than 2 minutes, okay. So what do we know about frailty? We know that there are problems which is causing physiological, biological problems, hormonal problems, but we do not have consensus definition for frailty. We don't have biomarkers for, to diagnose frailty, and there are no animal models. We don't know anything very much about frailty. Okay, so what do we have to do? We need to make the people aware, healthcare workers, people, everybody. We need to be very active against frailty, because frailty will make the person very dependent. You need to diagnose early, educate, do more research, and there need to be support system to help the person and the family and all. And what you need to do, think, is prevention and delaying frailty, physical activity, as we all know, then manage other conditions which can make somebody frail, and increase social relationships, promote active aging. That is very important. And your interventions will have to be to prevent retard frailty, because once you become frail, they will never become completely normal. So before that, you need to start doing changes. So exercise, physical therapy, so always be active. Not only physical activity, mental activity. Social interactions are very important. Nutritional interventions, good diet, but supplements do not have proven, they have not proven to have any much benefit. Then polypharmacy, Lekam was very well mentioned, and you need to do comprehensive geriatric assessment. Okay. Okay, so you can select which way you are going.
Yeah, I think you can answer the questions.
You decide which way you are going. You can either become frail and dependent, or you can be vibrant and agile. Okay, thank you.
Right, thank you very much, Madam, for that excellent talk. Let's move on to the next speaker, Dr. Dilha Samaravira. He's a consultant physician at Teaching Hospital, Colombo South Teaching Hospital, and he is the founder, president of Sri Lanka Association of Geriatric Medicine. He is going to talk to you on unraveling the mystique of elderly. Over to you, Dilha.
Thank you, Chairman, for the lovely words of introduction. And of course, I must remind you that he's my very good friend, Dr. Uluwatta. He's been my co-VP, and also our pretty physician, Priyamali, is here. So just to give you a presence of the situation here. So anyway, first of all, I would like to thank the President Professor Tilak Jalat and the council for inviting me to do this lecture. And also I must mention, I know I'll be running out of time, but I must mention about our Dr. Suranga Manilgama, who insisted that I do not repeat things in this lecture and that new cases have to be discussed. So let's start. Unraveling the mystic of the elderly. So, well, this is a repeat slide, but I must tell you that this is very important because you must know the different ways the elderly present you. So the 5 I's that everybody should remember: intellectual failure, incontinence, immobility, instability, and iatrogenic illnesses, about which Professor Lekamsam talked in the first lecture. And of course, atypical presentations, which I'm going to talk today. Myocardial infarction presenting as a fall or confusion. Thyrotoxicosis presenting as lethargy, slowness. And of course, about multiple pathologies. So unlike what we learned as medical students to accumulate all the physical signs and symptoms to come at one diagnosis, here we talk about multiple pathologies in one person and multiple diseases in one person. You know, as people age, they accumulate these illnesses. And of course, erroneous attribution of symptoms to old age. This happens either way. Elderly think that some of the symptoms can be taken for granted because of old age, and also the younger people, even the people at home or even the doctors think, okay, these are problems of elderly and do not need assessment. And the single illness leading to catastrophic consequences, of course, this is the classic example is the COVID-19, where we see an elderly person catching a viral illness, and due to the viral illness can become delirious, and then they can have a fall. Fall can lead to a fracture. Fracture leads to immobility, hypostatic pneumonia, and death. And this is what happens in the frail elderly, which we discussed in the previous lecture. So, coming to atypical diseases, definition of an atypical presentation of illness is when an old adult presents with a disease state that is missing some of the traditional core features of the illness usually seen in younger patients. The traditional core features are what we learned as medical students. Atypical presentations usually include one of 3 features: vague presentation of illness, altered presentation of illness, or non-presentation of illness, that is underreporting, which you will get to know as we discuss the cases. The most common risk factors for atypical diseases are increasing age, especially age 85 years or older. Even in the first lecture for drug interactions, that's the age given. Being on multiple medications, polypharmacy, having multiple medical conditions, multimorbidity, that is having 2 or more chronic diseases, cognitive or functional decline, physical as well as mental decline, and frailty, which we talked about. Common warning signs and symptoms across a wide spectrum of illnesses need to be known. New decline in functional status. Now, this is what I tell most of the trainees. Always ask about the pre-morbid status of a person. Then only you will know. The relations will tell you, or the caregiver will tell you how much has changed within the last 1 week or few days, or within the last 2 months. This is vital in identifying a new illness. Change in behavior, agitation, increased confusion, maybe sleeping more, maybe very lethargic or depressed. And of course, other symptoms, other situations like falls, symptoms like anorexia, generalized weakness, and most of the geriatric syndrome, the 5 I's that we talked about. So we come to a case history. Mr. M was a 68-year-old man who presented to the general practitioner with diffuse abdominal pain, vomiting. He had no fever. So examination revealed generalized abdominal tenderness. And as usual, the general practitioner will see a patient, an elderly person, coming with some abdominal pain and some vomiting. So diagnosed as most of you will diagnose gastritis. Here, he thought it's gastroenteritis, but there was no diarrhea, so that's probably a wrong diagnosis. And he gave maybe some medicines and some probiotics. 3 days later, and some proton pump inhibitors. 3 days later, he presented to the general practitioner with a fever. This time with fever, weakness, bloating, and anorexia. Then the doctor did some blood test. The white cell count was somewhat elevated, not very elevated, and the urinalysis showed pyuria. So there were pus cells in the urine. So the doctor diagnosed a urinary tract infection, and the patient was prescribed ciprofloxacin. Patient reported by telephone next day, and the doctor was courteous to give his phone number, and the patient called and said, "I'm better." So later, however, he turned up again, complaining of increasing right lower quadrant abdominal pain, and he was very ill, and then the ultrasound scan abdomen revealed a large appendical abscess. So he stayed in the hospital, required drainage. Now, what happened in this patient? Initially, the patient came with an abdominal pain. The history was taken as a gastritis or gastroenteritis. What is important is to diagnose this as undifferentiated abdominal pain, and then find out the reason for this. And the other fact is, the patient came with a fever next time. Fever is most often absent, but this time came with fever, yet the white cell count was elevated mildly, and the UFR can have pus cells. It's a very common manifestation in the elderly. And the patient was given ciprofloxacin, got better. Why did the patient got better? Because the abscess, the perforated. So therefore, you get a false sense of being better, paradoxical improvement, and then caused peritonitis, and he came back. So there are many lessons for us to learn. Often abdominal pain is absent or diffuse in the elderly, and the classic signs of appendicitis, such as right lower quadrant pain, fever, and nausea, all these are not present in the elderly. Instead of fever, one may encounter hypothermia, and tachycardia is often absent in the elderly, even in sepsis. And mental state changes, confusion, agitation, lethargy, tachypnea, urinary urgency, constipation, poor appetite are potential presentations of an acute abdomen in the old adult. Elderly patients have a high rate of asymptomatic pyuria. So you know, sometimes elderly people, they have colonizing bacteria in the urinary tract, and they can anyway have some pus cells. So that's not to be taken when the clinical scenario is not consistent with it. And also, anyway, in appendicitis, because of the relationship with the appendix with the ureter, you can have pyuria or hematuria. So therefore, this diagnosis was missed. Now, it's important to realize that in elderly, as the presentation is vague, and when you examine, the examination findings are also very vague, and you may not find the guarding or rigidity that you encounter in other patients. You must have a lower threshold to go for imaging. You can go for ultrasound scan or CT scan of the abdomen very early in the disease, therefore that you don't delay in diagnosis, because delay in diagnosis can increase the mortality, has resulted in increase of mortality in the elderly, especially in abdominal diseases. So another patient, a man with acute functional decline. Now I told you that's a way of diagnosing a new illness, decline in the functional status. This is a 78-year-old man who has come to the emergency department with a 3-day history of weakness, falls, and confusion. His vital signs are as follows: systolic blood pressure 160, heart rate 78, respiratory rate 22, temperature 36.2. He has a past medical history with multimorbidity, as you see here, and also he is on many drugs. Hydrochlorothiazide 50, more than the required dose, losartan, and prazosin. So you can see how many antihypertensives the patient is on. And the patient is also on some painkillers for the osteoarthritis and some aspirin. So clearly he has multimorbidity and this polypharmacy. Patient had 3 to 4 day history of periods of confusion, forgetfulness, frequent repetition, agitation, and trouble walking. He fell 2 days ago while getting out of bed, and again this morning. So he has been repeatedly falling. So the functional status has declined considerably in this patient. He is usually alert and oriented. Now this is very important. Now he is a person who is usually alert and oriented. If you really go back to the history, you may also find that he has been forgetful during the last few months. Maybe he was developing mild cognitive impairment, which could be the predisposing factor for confusion this admission. So it's very important to find out the pre-morbid status. The wife was fearful that it was a stroke and called 1990. And if we had time, I would have asked you the differential diagnosis, but as there's lack of time, we'll discuss. So what could have precipitated this event, the new onset functional decline? Could be a cardiac event, such as congestive cardiac failure. Could be hyponatremia or hypokalemia due to diuretics. Could be postural hypertension with such a lot of medicines, and hyponatremia especially with a HCG of 50 and losartan and so many drugs. And the patient's sudden change in function and falls could be a sign of infection as well. The patient's full blood count was within normal limits. His sodium was very low at 115 millimoles per liter. So he had hyponatremia. And his ECG showed his old MI but no new changes. CT scan was all right. There were no fractures. But the urinary, the UFR, the microscopic urine test showed a urinary tract infection. So this time it was a urinary tract infection. Urinary tract infections are in fact the commonest causes. Out of the commonest cause, urinary tract infection is one of the commonest to cause confusion in the elderly. So now we come to another patient, a woman with a fall and delirium. So this patient, Mrs. K, an 80-year-old woman from Piliyandala, widowed mother of 8 children, gave a history of ischemic heart disease, not on regular follow-up. And she gave a history of having abdominal discomfort associated with shortness of breath after meals and on mild exertion, treated as dyspepsia with proton pump inhibitors and some Ayurvedic ointments as usual. She had no features of heart failure, according to the traditional ways of assessment. She's partially dependent on activities of daily living and instrumental activities of daily living. Her pre-morbid Barthel index was 65 out of 100. So there was considerable functional impairment in this patient anyway to start with. So the pre-morbid status also the patient is or can be considered as frail. He presented after 2 days with a fall and tragedy fracture of left side intracapsular neck of femur. The fall was contributed by multiple intrinsic and extrinsic factors. So you need to, when there's a fall, you need to find out what are the intrinsic factors, what are the extrinsic factors, what are the factors within the person to contribute for the fall, and what are the factors in the environment which contribute to the fall. History is otherwise negative for major systemic complaints. On admission, she was pale, GCS was 15 out of 15, but she was in severe pain, so it was difficult to assess, so it's probably 10 out of 10 if you apply the visual analog scale. So analgesics were started. On day 2 of inward stay, she was in pain and then she developed delirium. Comprehensive geriatric assessment was done with limitations and evidence of frailty was found, sarcopenia with mid-upper arm circumference of 17 centimeter. Mobility assessment could not be done as the patient was really difficult to handle in delirious state. Mini nutritional assessment revealed that she was at risk of malnutrition. She had stress and urge incontinence, an element of functional incontinence. She had reduced vision and hearing. So you could understand how difficult it is to do a comprehensive geriatric assessment in a patient who is delirious. So this was done with a lot of limitations. Cognitive assessment and the geriatric depression scale was not applied as the patient was very delirious. So the investigations were done. Full blood count revealed anemia, mild anemia of hemoglobin of 10. Sodium not low, just marginally low, and potassium being normal, creatinine normal. So most of these investigations, apart from albumin being low, were okay. Echocardium ejection fraction 15% and some wall abnormalities, hypokinetic segment, and no valvular pathology. So now this patient, on admission, the ECG was normal. So you know how difficult a delirious patient can be. They are really, staff would call that they are troublemakers. And the relations really don't like confused people. Nobody likes. So what happens is, even the doctors, they start calling other people, trying to refer the patient to some psychiatrist, or they do that. And we were also referred this patient. And initially, all the screening was negative. The ECG with limitation, that was found to be negative. But, well, we thought we should do a troponin I anyway, because it could be MI after all. And then we did a troponin I, and the troponin was positive. And then we managed to do the repeat ECGs, and they showed dynamic changes with anterolateral ischemia. So when a patient is delirious, we all try to calm the patient down. People try to tie the patient. People try to restrain the patient pharmacologically by giving many drugs. But what you need to do is find out the precipitants of delirium. Here, one of the precipitants was the pain, and the pain was addressed with subcutaneous morphine. And then the patient was better, and then the assessment revealed that the patient had a MI. So it's very important, because most of the time when you, in practical situation, in a lecture, well, it's just a word, delirium. But practically, it's a real problem, delirious patient. So you need to find the elephant in the room, we say, because there's a major cause causing the delirium. You need to find it, otherwise you will miss. And the other important factor here is that delirium can present in a very hypoactive manner. That is called hypoactive delirium. A delirious patient is not always agitated, can be calm and then would be lethargic, depressed. In that situation, you may miss the diagnosis. So it's very important to diagnose delirium. So myocardial infarctions can have no pain, no chest pain, and they may not be short of breath. New onset fatigue, dizziness, confusion can be a presentation. And heart failure may present with loss of appetite and fatigue rather than breathlessness. So remember that. So finally, this is a woman with fatigue. This is an easy case. I won't take a lot of time for this. 76-year-old woman diagnosed with type 2 diabetes and hypertension for 10 years, present with history of generalized malaise and fatigue for 1 month duration. She complained of difficulty standing from seated position, so some functional impairment. And of course, elderly people have constipation. She was treated with laxatives, but recently she has been starting to have some diarrhea with the laxatives. She had a subjective feeling of loss of weight. So she's a diabetic patient on these medicines. Anyway, BMI was 20. Neurological examiner revealed proximal muscle weakness. Pulse rate was normal at 84. So what is important is we did thyroid function tests. Always do thyroid function tests in the elderly, because you may find either hypothyroidism or hyperthyroidism. In this patient, it was hyperthyroidism, and she actually had Graves' disease. When we did the radionuclide uptake scan, the diagnosis was made. So lesson is hyperthyroidism. Well, the patient could have fatigue and slowness. The paradoxical way of presenting, it's an atypical way of presenting of hyperthyroidism. And hypothyroidism may present with confusion and agitation. So be mindful that if a thyroid function is unable for your patient, please do it. So my take-home message would be, attention to new decline in functional status compared to pre-morbid status is important in detection of an illness. Missing the diagnosis or delay in the recognition of acute illness leads to increased morbidity, prolonged hospitalization, and increased risk of death in the elderly. Non-specific signs and symptoms are more common than the classic signs that you see in the young. Unraveling the mystique of elderly needs careful assessment of those non-specific symptoms. Remember the 5 I's. Recognition of common serious illnesses in the setting of atypical presentations in older patients is becoming an increasingly essential skill in clinical diagnosis and treatment. Thank you very much.
Thank you very much, Dr. Dilhara Samaraveera. That's very comprehensive talk and on time. May I invite Dr. Dilhara Samaraveera and Professor Chandrika Jayasinghe to the stage. Now we have 8 minutes for questions. if you have any questions, this audience or a virtual one. Professor Lekambasam is there virtually if you have any questions.
I think I can ask one question from both of you and especially Madam. And the frailty is a very common thing in our day-to-day practice. But can we, is there any validated tool that can be used in ward setup to recognize frailty with, fairly reasonable accuracy?
Yeah. Now that's what I said, that there are two things. When you see the patient, as Dilhar very correctly said, that in a bilious patient, you obviously cannot do comprehensive geriatric assessment unless you have already done and you have the patient's geriatric assessment score with you, then you know that what kind of problems are there. But it's a new patient, the phenotypical method that what I have showed you all, that 5 things, will give you some idea whether the patient is frail or not. But then that patient has to be a patient who is not disabled. But later on, you need to always follow it up with that frailty index. Now, frailty index, in fact, we can decide what we are going to include. We can decide number of items. Now we do I think they also do comprehensive geriatric assessment. In that geriatric assessment in our clinics, what we do, we have we find out about patients' previous illnesses, drugs, other problems like psychological problems, other disabilities, vision, hearing disabilities, then activities of daily living. So you know the extent of deficits and the number of drugs, as I mentioned. So from that, you can have ultimately you can get a score, and then you can review it time to time to see whether the patient is deteriorating or whether the patient is improving.
Dilhar, do you want to add anything on that?
Yeah, I would like to comment on that, because we have found that frailty scales, the clinical frailty scale or the clinical or the frailty index is very difficult in the practice. And the other thing is there are we miss certain elements when we do these frailty scales, because some of the frailty scales only address the physical aspect. Some aspects like the social aspects, the mental aspects are not addressed in some frailty scales. But what I would recommend is we have been practicing the integrated care of older persons WHO model. You can, if you go to the internet and if you just type ICOPE, ICOPE, then you can download this module. Here we assess 6 domains. It's a very simple way, and it's a 2-step involvement in the assessment. So the 6 domains would be cognitive assessment and the mood assessment, and assessment of vitality, that is nutrition, assessment of mobility, vision, and hearing. So it's a very simple way, and we have a 2-step approach. Anybody can practice this. It was intended to be practiced in primary care, but you know what is intended to be practiced in primary care suits very well in our countries to be practiced in the tertiary care centers. So that's my recommendation. Use the ICOPE model. We actually intend to do island-wide program on this. The physicians can take part in this, and I would encourage all physicians, all doctors who are interested in geriatric medicine to go through this ICOPE model.
Okay, thank you very much. Sir, if you want to add anything or you have anything to highlight on your...
No, I'm fine, yeah. I think that's quite adequate explanation, thank you.
I have one question. It's very common in elderly, we come across that elderly patients commonly complain about loss of appetite and loss of weight. I think it's part of aging also. But sometimes when we wonder to what extent to investigate, when we find something, I mean, when we assess and investigate to a certain extent, right, basic investigations and, possible, investigations, sometimes we wonder to what extent we should investigate, because the incidents of malignancy and things also common in, elderly. It's a problem of, a common problem of elderly. So, it's a very practical, situation where physicians stuck to what extent we should investigate and consider, like, if you can give some, thoughts or some guidelines about it.
Sir, would you like to answer?
I don't know whether he heard it clearly, but I think Dilha can start.
Yes, that's a very pertinent question, not only loss of appetite. Say for instance, constipation. Now, these are symptoms that are common in old age. Loss of appetite, constipation, all these are very common. And joint pains. So they all come with these symptoms. So we need to find out, as I told you, whether there is a new functional decline, whether the loss of appetite is new, whether the loss of appetite has actually resulted in a significant loss of weight. So whether there are warning symptoms and signs in this patient which need to be investigated. So it's actually clinical. So geriatric medicine, there's nothing special about it. It's our day-to-day physician's job. So what we need is to identify in the context of very complex situations, because the elderly, they have multiple complaints, multiple signs and multiple etiologies. So you need to sort out and find out, okay, is this an important sign which could be a malignancy, a silent malignancy, a silent disease. Atypical presentation in malignancy is non-presentation. So you need to find out whether this loss of appetite is new, is associated with warning symptoms and signs, and then proceed forward with that. I do not know whether I have answered your question, but it's a difficult question.
In the constraint of time, we are actually on time. We would like to conclude the session thanking all three speakers and the participants here and the virtual participants. And may I invite my co-chair, Dr. Vimala Siruduwathage, to give a token of appreciation to our speakers. Professor Chandrika Jayasinghe. Dr. Dilhar Samaraveer. So you may join the lunch.